And a petu lashte, everyone. Thank you, everyone, for coming for this South Dakota Healthy Nutrition Collaborative. We appreciate every single one of you. My name is Irona Howe, and I am a part of this collaborative. It's been a blessing, and so much knowledge has come. I've learned so much from each and every single one individual. So I'll tell you a little bit about myself. I live on the Cheyenne River Reservation. I am a member of the Cheyenne River Sioux Tribe, and I work for the CRST Buffalo Authority Corporation. And my job is to implement buffalo meat on the school menus across Lakota country. So welcome, everybody. Really glad you made it. Really glad you're here. And I will pass it right over to Deb.
Well, good afternoon, everyone. Deb Fischer Clemens, and I have the honor of introducing the South Dakota Secretary of Health to give our opening comments. It seems like yesterday that Secretary Magstadt kicked off our event, which was a year ago, and had comments then, and we look forward to her comments today. So Melissa has been involved in South Dakota healthcare for over 30 years. She is an advanced practice registered nurse and a co-owner of Quick Care South Dakota. She also served in the South Dakota House of Representatives from 2011 to 2014. She was a member of the House Committee on Health and Human Services, and I can tell you she did a fabulous job there, as she is doing today in her role. Her education includes a master's in science from South Dakota State University with a focus on family nurse practitioner. She also has a master's in business administration from Mount Marty University, my alma mater, so I'm grateful for that. She graduated from the Great Plains Public Health Leadership Institute at the University of Nebraska and recently completed her fellowship at the University of Arizona Center for Integrated Medicine. She is someone who is always learning, always finding new things to find out about and talk about. She was born and raised in South Dakota, residing in the northeast part of the state. And with this, I would welcome Melissa Magstadt, our South Dakota Secretary of Health. Thanks, Melissa, for joining us.
Thank you, my friend. What a kind introduction. And I appreciate always the words of encouragement that come from you and in the work that we do over the Department of Health. I am very excited to celebrate a year with you. Yeah, how fast a year goes by. And I remember that day, there was some construction working as we were doing that original kickoff construction, but by gosh, we persevered through it anyway. Just setting an exciting pathway of what possibilities are. And what I appreciated back then is how many diverse groups of folks were committed to making this type of impact on behalf of our state. I think we all know in this group, I'd be preaching to a choir to this group about acknowledging that one of the pillars of a healthy population is access to and consuming of healthy, nutrition-packed foods. And where we also acknowledge that for some that's easy to accomplish. For some, that's not quite as easy to accomplish. And for some families and communities, it's a little harder to make sure that each one of those community members have access to healthy foods consistently. You know, I think one of the trends that I've seen in the years of healthcare, and I think it's probably a really good acknowledgement, is that 20% of our outcomes for healthcare have to do with actually what we do in healthcare. So, you know, I have loved being in healthcare for, 35 years and still going, loved it, would never have changed pathways of what career choice. But I think I'm at this point now, and I think all my healthcare colleagues would agree that what's done in the healthcare exam room or at the hospital bed is a small piece of what actually contributes to that person's outcomes in healthcare. And now there's this thing called the social drivers of health, is that acknowledgement that yes, the bar of excellence, so for what a healthcare provider does in their job, it needs to be of a high bar of excellence, absolutely, each and every time. But then there's also this this acknowledgement that that's 20% of the outcomes. So whereas the rest of the 80%, well, it turns out 30% is what Melissa does on a day-to-day basis. You know, her consuming healthy fruits and vegetables daily, her being active, her not using tobacco, whatever it is that helps contribute to healthy being. I would say that nutrition is the big piece of it. for just about everything relates to how well we manage our diet and how well we are able to consistently take healthy foods daily. But the other piece of it, how easy is it for Melissa to obtain those foods, right? So there's the part of me wanting to eat healthy daily on a day by day basis, but there's also the piece of how easy is it for Melissa to be able to do that, whether that's be financially ease or logistically ease or whatever that types of is. So that 10% of contribution to healthcare outcomes is the environment that we live in. And then the 40% is that social economic pieces, education levels, poverty levels, access to healthcare, not the actual healthcare, but the access to healthcare, but also the access to healthy foods. So Melissa needs to take them daily, but there has to be a way for her to be able to obtain those in a way that is easy for me to get healthy foods for my family as well, or be able to afford them. So I think the work that you're doing undergirds pillars of health that maybe have been disregarded in the past in healthcare. As we focused on the sparkly, most innovative, most advanced way of doing healthcare, coming back to the foundations of how does America eat and how well do they feed their children, how well do they feed their pregnant mothers, is going to be even more impactful than the next new shiny innovation. And I think so what you're doing here is very much that core piece that if we get this right, so many other things come into order because we did this right. So thank you for your commitment to that and your faithfulness in executing. The South Dakota Department of Health, we've really sort of shifted our priorities to come along with those social drivers of health as well. And one of the areas I wanted to call out that we're very proud of is that we are the state public health department that has the Women, Infant, and Children's Program, the WIC program. The WIC program is 50 years old, and we serve 14,000 mothers, pregnant mothers, infants, and children every month. Every month. Not only do they get food from us of healthy foods to help feed their families and keep these pregnant women with healthy diets, but they also are paired up with a nutrition counselor and a dietitian to help them learn to develop the skills to eat healthy themselves, but also feed your family healthy. Just because you have a family doesn't mean you automatically have this superpower of knowing how to cook for them and how to create meals that are healthy. And so we come alongside those families to make sure that they have access and that they know how to do it. So improving the importance, but also reducing the barriers to access to those healthy foods. 75% of our MIC mamas choose to breastfeed their kiddos. We're a big proponent of nursing and breastfeeding. Think that is the best way to provide healthy nutrition for babies. And so we're very excited that we have such a high record. And our reach goes very, very far in the state of South Dakota. 98% of women, infant, and children that are eligible for WIC services get WIC services in our state. That is not true for all other states. This has been a very concerted effort by the WIC team to make sure that if you're eligible and you need us, that we find you and get you connected. 98% the time we are getting that done. So we even truly invested the time and resources into starting out families and infants and kiddos well, and to make sure that they get launched well. And we appreciate this mission with the collaborative to do the very same things for the citizens across our state, whether there are elders, whether there are communities that are maybe new even to English as a second language. You know, we've got some very unique populations, our tribal nations, and making sure that wherever you choose to live, that you have the best nutrition available for you and your family, wherever you put your roots down in South Dakota. It's good living out here. It's just sometimes there's some frontier and rural access that makes it challenging, but it's still good living, even if you choose those rural and frontier communities. So thank you to the collaborative for your vision and your commitment. Thank you to everyone on this webinar for the work that you've done to elevate this in your own sphere of influence. And we'll continue to do the same in the Department of Health and look forward to celebrating a second year of good things happening from the collaborative. So congratulations, and get to work on the second year.
Thank you, Madam Secretary. We appreciate your opening remarks so much, and I always value your input and look forward to working with you as well. So thank you so much. Irona, I hand it back to you.
Actually, Deb, I'm going to take it from you.
Okay, good.
Jen Folliard, steering committee member and coordinator for the South Dakota Healthy Nutrition Collaborative, and I have the pleasure of introducing Dr. Gemma Bastian. Dr. Bastian is an assistant professor and extension nutrition and health specialist at South Dakota State University. Her work focuses on improving community nutrition programs, local food systems, and healthy food access across South Dakota. She leads the South Dakota State University Extension initiatives like Dakota Food RX and the CDC High Obesity Program, and co-leads a national research group advancing the expanded food nutrition education program. With that, I'll hand it over to Dr. Bastian to give us an overview of recent statistics around food and nutrition insecurity.
Thank you, Jennifer, and welcome everyone to our Healthy Nutrition Collaborative 1-year annual conference. It's just been such an amazing experience getting to be part of this group, and especially being on the steering committee and getting to learn from not only the other steering committee members, but a lot of the other folks who have contributed to our working groups and in this very complex but very worthwhile space in food and nutrition security. So we have a lot of folks here today. Some of us have been in the space for a very long time. Some of us might be completely new to what food and nutrition insecurity might even be. So I'm going to give a brief overview so we all can kind of have the same definitions and have the same language to use when we're talking about these pretty complex topics. Next slide. So when we're looking at food security, there are a lot of different definitions, and we get a lot in the literature, we get some by governments, but I really like this definition by the Food and Agriculture Organization of the United Nations. You can see here that they state food security as being when all people at all times have physical and economic access to sufficient, safe, and nutritious food that meets their dietary needs and food preferences for an active and healthy life. So you can see that it's a pretty comprehensive definition. It's not just about having enough food, it's about being able to afford the healthy options. It's to making sure that we have the adequate food for healthy pregnancy, healthy childhood, healthy adulthood, healthy aging, really throughout that entire lifespan. Within this definition of food security, we see 4 pillars or subconstructs of food security. So you can see that the first one is availability. This is whether food is or is not available. So this often has to do with agricultural factors such as, droughts or storms impacting crops, or other issues in the food supply that might make it more or less available to have foods in certain areas. The second pillar is accessibility. And this is when food is available, is there adequate access to those foods in all of our communities? So if you've ever been to a very rural frontier community, perhaps right here in South Dakota, you may have been to a grocery store and noticed that there might be less access to certain foods such as fruits and vegetables, or the ones that there is access to might not always be the freshest, or they might be extra expensive. So that would be an issue with accessibility. The third pillar is utilization. And so not only do you have to be able to have access to the foods in order to live a healthy lifestyle, but you also have to be able to utilize them properly. So this is about people, consumers, households having the ability to properly cook, store the foods that they acquire. So as you can imagine, let's say someone is unhoused and they don't have the equipment to cook the healthy food. It doesn't matter how much healthy food they get. If they can't utilize it and properly cook it into a healthy meal, then it's not going to be correctly utilized. We also see a lot of knowledge deficits in terms of cooking healthy meals. Let's say you get a bunch of healthy farm fresh produce and you don't know what to do with it or how to even prepare some of the produce that you get. That would be a utilization issue as well. The fourth pillar, stability, really synthesizes the other 3 pillars and really talks about how, in order to maintain food security, that the other 3 pillars have to be stable over time. So when we see disruptions in, say, seasonality of certain food supply chains, or perhaps even with seasonal work, people lose their job and then don't have the means to access the foods that they used to be able to access. Those can be disruptions in stability. Next slide, please. We also see on a countrywide level through the USDA measures that we also look at household food security and label households as being either food secure or food insecure. So you can see that the food secure categories are highlighted here. There's two different types, high food security and marginal food security. High food security is when there's no real reported indications of food access problems or issues with um, accessing those foods. With marginal food security, there might be some anxiety in the household. Perhaps, oh, I'm running out of money towards the end of the month. I'm not sure if I'm still going to be able to put food on the table, but there's not necessarily indicated changes in, say, what types of foods they're eating or their access to foods. When we start looking into food insecure, that's where we see low food security and very low food security. So when you get into low food security, maybe they're reducing the quality of their diet or maybe a little bit of how much food they're eating, but it's not as drastic. And so, for example, if you have, like, say, a broke college student that maybe is living on peanut butter and jelly sandwiches and ramen noodles, that might be low food security where they're still accessing food, but it's not the right quality of food for a healthy diet. And then finally, we see very low food security. This is where we see really disrupted eating patterns, such as skipping meals or reducing the size of meals in order to utilize very, very limited food resources. So that would be very low. Next slide. So, looking at these definitions of food insecurity within the US, we can see here that the most recent statistics come from 2023. And so we can see that 13.5% of US households were considered food insecure in 2023. You can also see the breakdown with 8.4 of them being households with low food security and 5.1 being households with very low food security. Looking at the graph on the right, this is looking at those trends and how they've changed over time. And so the top bar is food insecurity, which is low and very low, and then the dashed line is very low food security. And you can see that both of them have increased in the last few years. There was, you know, food insecurity that was definitely experienced during the COVID-19 pandemic. However, with some certain policies that we had, such as stimulus checks and increased eligibility for programs like SNAP, we actually saw a little bit of a decrease during the COVID era. And then as those programs ended, combined with other economic policies such as mass inflation, we've seen a bit of a rise in food insecurity over those last few years. Next slide. Looking at groups who are more likely to experience food insecurity, there are definitely disparities in different groups. Particularly, we see higher food insecurity among single parent households, particularly those led by a single mom. We see it among Black and Hispanic households, households that are low income. So we consider that less than 185% of the federal poverty line. So households eligible for programs such as WIC or SNAP. Also, we see disparities in both urban and rural households. Sometimes, I talk to folks across the state and they say, oh, there's no food insecurity in Sioux Falls. Well, there is. There's actually tons of pockets of food insecurity. And there's a really great comprehensive report by Augustana Research that has highlighted a lot of those pockets of food insecurity. So it's pronounced both in our rural and our urban areas. And then also looking at regions across the US, we definitely see higher food insecurity in the South compared with other regions. Next slide. So now looking at food insecurity in South Dakota, the most recent statewide statistics are from 2022, where we see 11.7% of South Dakotans face food insecurity, or over 106,000 South Dakotans. This is a little bit lower than the national average was that year, which was 12.8%. However, that doesn't mean that food insecurity isn't a rampant issue in our state. As you can see from this mapping the meal gap map of our state, the counties are colored based on their different prevalences of food insecurity, with the darker colored counties having higher prevalence of food insecurity. So you can see actually our Oglala Lakota County actually has one of the highest rates of food insecurity in the entire country. So we see a lot of disparities, especially in our rural frontier counties, as well as counties that are housed within Native nations. And so we see that there's a lot of disparities in the state, even if overall our state is a little bit lower than the national average. Next slide. So, why does food insecurity even matter? Of course, it's important to make sure that everyone is able to access healthy food, but what does it actually mean when we see chronic food insecurity over a period of time? As many people probably on this call know, poor nutrition leads to several diseases such as heart disease, diabetes, certain types of cancers. In fact, 7 of the 10 leading causes of death are diet related, and those causes kill 1 in 5 Americans each year, who die, obviously not 1/5 of the population each year. And then more importantly, chronic food insecurity and chronic disease are really intertwined and actually exacerbate each other. So if you look at this graphic on the right, you see the cycle of food insecurity and chronic disease. So you can see that food insecurity often leads to those coping strategies, such as reducing the quality or the amount of food consumed, which then leads to those risk factors to chronic disease, which means more missed work days or just more healthcare expenditures for managing conditions, which means less money to spend on food. And so a lot of times it's cyclical and it compounds upon itself, so it can become a cycle that's really hard to get out of. Next slide. And so this has led to an initiative within the past few years, not only focusing on food security, but nutrition security. So this has been defined by the US Department of Agriculture as when all Americans have consistent and equitable access to healthy, safe, affordable foods essential to optimal health and well-being. So if you are, a researcher or very pedantic like me, you might be like, well, that sounds very similar to the definition of food security that we're already rocking with, right? But I think it's important to really place a highlight on nutrition security because for many years, a lot of our programs and efforts to solve food security was just about getting food in mouths, right? As long as people are being fed, then we're solving the issue. But because of that, sometimes efforts that were well intentioned to combat food security ended up putting unhealthy foods in bellies. And so, again, with poor nutrition over many years, that does lead to the exacerbation of chronic disease. So, President Biden kind of talked a lot about nutrition security at the White House Conference on Hunger, Nutrition, and Health. This was the first one that was held since 1969. So, it was a really iconic moment in terms of addressing this on a national scale. Next slide, please. And so finally, I want to end with a definition of food is medicine or food as medicine, which is also a pretty common term that we discuss in our collaboratives work. And this is actually really a whole suite of different types of interventions at the policy level, the community level, as well as the clinical level that aim to prevent, these diet-related chronic diseases. So the graphic here is what we call the food as medicine pyramid. Basically, the way that it's read here is that at the bottom are programs that are more focused on preventing disease, and the programs towards the top are programs that are focused on treating disease. So you can see that at the bottom are population level healthy food policies and programs, such as SNAP and WIC are down here on this area, which help again help people increase their access to healthy foods. And then as we get towards the top, we start to see programs that can actually help treat diet-related chronic disease, such as produce prescription programs, such as the Food as Medicine study with the Vera Research or the Dakota Food RX program, as well as medically tailored groceries and medically tailored meals, which are much less common in South Dakota, but would be really wonderful to see programs like that start to flourish in our state. So with that, I think that was my last slide. It was. All right. Well, thank you so much for allowing me to do this overview. I am a researcher who studies food insecurity, as well as someone who runs programs to kind of meet people at this intersection of food insecurity and health. So if you have any questions, of course, throw them in the Q&A, but you can also reach me here through my personal lines. So thank you.
Thank you, Dr. Bastian. I think that gave us a really great overview of what we're looking at and level set of what we're talking about when we talk about food and nutrition insecurity. Thank you for bringing your expertise to the table. My name is Jennifer Folliard. I'm one of 6 steering committee members for the South Dakota Healthy Nutrition Collaborative. I'm also the coordinator for the collaborative, and I have the pleasure of going over our goal group progress and impact. But to start off, I do just want to give a little level set about where we've come from in this last year and think about, so that we can understand where we're going. So beginning in 2023, we did have sort of this coffee table conversation with Feeding South Dakota and the American Heart Association, really thinking about we know that there's an issue in our state. We know that folks want to come together and talk about this issue. How are we going to do this? And so we started having those conversations. We decided to start expanding who we were bringing into those conversations to talk about how we develop this collaborative and what is that going to look like? What is the structure of it? Who's invited? How do we work? And our draft structure was approved in 2024, early 2024. And our first collaborative meeting, even before we announced the collaborative, right, was in March of 2024. So, it is important to recognize where we've come from as we think about where we're going. That initial advisory group did agree upon the purpose and the idea that we would convene a coalition. We developed sustainable practices to engage individuals with lived experience, identify goal areas, and I'll talk a little bit about what those goal areas are. And we identified sectors and individuals from those sectors to invite to be part of our larger collaborative or coalition. We agreed upon shared governance. So we outlined the problem of food and nutrition insecurity in South Dakota. We identified steering committee and membership responsibilities. We talked about how we make decisions, and we identified our purpose and goal areas. And we asked for formal support of this shared governance model or our charter. And from that, and I know these logos are very small, and I would encourage you to go to our website to really look and see which organizations are part of our collaborative. But with our shared governance model, we were able to get we have 40 organizations that have signed on to say they will be part of this larger collaborative. And we have a variety of different organizations from many sectors, from the business and retail sector, from the healthcare sector, community-based organizations, food banks, food pantries, local food hubs. We have a variety of different groups that are here at this table talking about how we can improve food and nutrition insecurity in South Dakota. We organized ourselves into goal groups, and the first goal group is to improve coordination, identify areas for statewide research, evaluation, and promote programmatic best practices to improve South Dakotans' food and nutrition insecurity. Our second goal group was to elevate the voices of food and nutrition advocates, researchers, and individuals experiencing food and nutrition insecurity. And our third is to advance policy implementation to improve food and nutrition insecurity in South Dakota. And these goal groups really represent the work that's happening on the ground to address these big buckets of concern. So as we gathered in March and identified which organizations wanted to be part of which goal group, those goal groups continued to meet. And so we developed, each goal group had strategies. So you'll see goal 1 to improve coordination, identify areas of statewide research, evaluation, and programmatic best practices. Our strategy when we came together in those meetings was really, we needed to identify funding to get a statewide landscape assessment of organizations, programs, and policies that address issues related to food and nutrition insecurity. And that was a big ask. And sort of what we realized from that is that when we do that assessment, and I'll back up a little, how we came to that is that all the organizations that were part of that goal group area had some little bit of an assessment that might give us an understanding of what the landscape is in South Dakota. And so we all came together, we put all of our research into one big shared folder, and we looked at it and said, okay, we need some more funding to really identify if there's gaps here and then how we move forward as a state. Our next strategy was to create a resource hub for programs and educational materials. And I will say that is one that will probably carry on into next year. It's an important strategy for us, but maybe one that we didn't quite get accomplished this year. Goal group 2, to elevate the voices of food and nutrition advocates, researchers, and individuals experiencing food and nutrition insecurity. Our strategy was to create a system for lifting up individuals' voices in South Dakota who experience food and nutrition insecurity, and that's respectful of time and energy of these individuals. And I would say that that strategy has been successful in our collaborative. We do have folks that have shared their story, continues to share their story and provide input as we're identifying priorities and any sort of action areas in any of these goal groups. But I still think that one is one that will probably carry into year 2 as well. And then in our goal group 3, to advance policy implementation to improve food nutrition and security in South Dakota, we really focused in on 2 strategies. One was develop broad policy principles that represent the collaborative's interest. And the next was to educate decision makers and the public about food nutrition and security. This goal group also supported the idea that we need a broader landscape assessment to inform good policy discussion. And I would say we did a great job in that policy goal group. We did create policy principles. We decided on a consensus decision-making model within that policy goal group to say we need to foster discussion about policy options and think very deeply about how policy is implemented in the state. So I did want to just reflect a little bit on some of the outcomes that we've had for year 1, and 3 buckets of themes came out for me. One was commitment, the next was awareness building, and the last was growth. And so for commitment, we had 40 organizational members from a variety of sectors sign on to this charter and this idea of a collaborative. We engaged 6 very committed steering committee members, and we met at least 12 times a year. I feel like with some of you, I feel like I'm meeting every week to discuss, what's going on and, the changing landscape of food, nutrition, and security in the state. We have 100 engaged individuals in statewide, from statewide in 3 goal groups. And we've convened about 20 meetings of those goal groups over the past year. And we've continued to engage individuals with lived experience in our decision-making throughout the collaborative's work. Our next bucket of work is really around awareness building. So we've engaged individuals statewide through communication channels like we developed our social media, our branding, YouTube development, and our listserv. We've reached 100 state legislatures, and we've introduced them to the South Dakota Healthy Nutrition Collaborative through a welcome letter in the last session. We've met with federal members of Congress to introduce them to the South Dakota Healthy Nutrition Collaborative as well. And then growth. Again, I mentioned our policy principles document. I feel very, very good about the work that was done in that committee. Again, working with a consensus-based decision-making model really invites conversation and discussion. And when we're thinking about policy and we're thinking about how we're going to work and those policy principles that were developed, that deep discussion is necessary. We've also submitted 6 funding proposals to develop a statewide landscape assessment, and I'm happy to say that 2 were awarded. So congratulations and a huge thank you to Avera Research Institute, who was the submitter of those proposals and will receive and do the landscape assessment for the collaborative in the coming year. And I would say also that we've had multiple partnerships formed to address food, nutrition, and security over the years. And the collaborative gives a space for people to have those conversations and to really create synergy and create more competitive applications for funding opportunities in South Dakota and throughout the country. So with that, I'm going to hand it over to Tony. We are going to zoom out a little bit to a national landscape to hear from a policy leader with insight into what's happening in Washington, D.C. And Tony Burke, one of our steering committee members, will have the pleasure of introducing our next speaker.
Thanks, Jen. I wouldn't be remiss to say, but I'm super proud of the work that we've done over the last year, listening to Secretary Magstadt and some of her comments, and you listening to your review of this year. It's kind of, sometimes we forget how many of the accomplishments we do until we actually take that pause to learn and listen what we've done the last year. So super proud of all of us and what we're doing together, which I think is really going to make a measurable impact in the long term. Next, I am super excited to introduce Kristy Anderson. She is our Director of Federal Government Relations with the American Heart Association, a recognized expert and thought leader in nutrition policy. Her current role, she has oversight of over all the federal legislative activity across the organization's advocacy priorities. With over 24 years of experience in public health, Kristy has worked in both the nonprofit sector and on Capitol Hill, including serving in Senator Tom Harkin's office. She's held roles with the RAND Corporation and the Robert Wood Johnson Foundation Center to Prevent Childhood Obesity. She holds a Master's of Public Policy from George Mason University and a BA in Political Science and International Relations from Drake University. Beyond the script, which I'm really appreciative, Kristy has actually connections in South Dakota, which is really exciting. So when she got asked to do this, she was able to get reacclimated with Jen, our coordinator. So she does have a passion for this space and a passion for our state. So really super excited to turn it over to Kristy Anderson. Thank you.
Great. Thanks, Tony. And Tony, you forgot the most important part to mention, which is I'm a fellow Midwesterner, born and raised in the Omaha suburbs. So it's always lovely to be back among my Midwest folks. Next slide, please. And next slide. All right, so today I'm going to blow through a lot of information that is a lot of word heavy and in a very short amount of time. So after this call, this Zoom meeting, I will be making my slides available to share. So you can go back and look, because there's a lot. I feel like there's a lot, and also there's not a lot. I call it the sprint to nowhere. So it's interesting times in Washington, D.C. So I'm going to talk a little bit about reconciliation, or what we also known as the One Big Beautiful Bill, appropriations process, and Farm Bill. Those are really the three things at the federal level that have a large impact in nutrition policy. Next slide, please. And I'll probably miss something that you're very interested in. And if I do, I apologize. You'll have my email at the end of this presentation. My inbox is always full, but these are kind of all the things that are happening right now. And next slide. And last year, there were 1,154 pieces of federal legislation that dealt with nutrition. So there's no possible way in 20 minutes I'm going to cover every single thing. So, all right, next slide, please. All right, so what is reconciliation? We just got it done. It, sucked all the air out of the room. So it's really a procedure every new Congress. So every 2 years we have a new Congress that allows them to make spending changes on what we call mandatory programs. We have mandatory, we have discretionary. SNAP, school meals, those are mandatory. GovSNP is a mandatory program now through the last Farm Bill. Prior to that, it was a discretionary program. WIC is a discretionary program, and I'll get into that a little bit more in appropriation. So reconciliation really only happens when the same party has controlled the House, Senate, and presidency, and they can do it multiple times in that time. And again, it must look at just mandatory programs. And it's basically just a way to rejigger the budget. Next slide, please. And the thing that always concerns me about reconciliation, regardless of, I am so sorry, regardless of who is in charge, what's going on, is reconciliation is filibuster proof, which is why everyone at the national level was kind of freaking out about it, whether good or bad, because you only need 51 votes in the Senate instead of the hypermajority of 60 when it comes to spending bills. Next slide. So here are the nutrition provisions in reconciliation. And one step back, I'm sorry, on the filibuster proof, another point I wanted to make. And that's why there was a lot of drama, there was uncertainty, and why it's very unusual, but the vice president was around in case he needed to be the tie-breaking vote because it was that close in the Senate. And it was close in the House too, but the House doesn't have the filibuster. All right, so back to this slide. The provisions in reconciliation. So we know it's going to reduce SNAP funding by $186 billion through 2034 through a variety of means, new work requirements, higher state matches, limits on the thrifty food plan. So South Dakota, your SNAP error rate is at 3% if memory serves. And so as far as the changes in reconciliation and the cost share, you all will not have a cost share on SNAP benefits. However, the amount you all are paying when it comes to the administrative fees increases. And so what we see with these sorts of things is you see, 3 million people are going to lose access to food assistance. We're going to see slowed SNAP growth through USDA not being able to do thrifty food plan updates beyond inflation. And more states, this is a real worry we're having at the federal level, is that states may just opt out of SNAP altogether, and we're going to see food insecurity and nutrition insecurity rise significantly. Next slide, please. Okay, these next 3 slides are the ones I'm really going to blow through because it's a lot of information, and I'm sure these are the things that you want to sit down and look through, but these are all the changes to SNAP. So I already mentioned the thrifty food plan, that's immediate. The changes in work requirements, that doesn't go into effect until 2030. And some of these things, when I say when they go to in effect later on, that gives me a little hope that maybe we can change things between now and then. That gives us 5 years. For those who care about the utility allowance in SNAP, that is changing. Next slide, please. Internet expenses, those are changing for SNAP beneficiaries. And then the next row here talks about the state cost share, less than 6% error, 0 pay for SNAP benefits. So that's where you all sit in South Dakota. The federal cost share for administrative fees, that rises to 75% for each state. And so that's going to be an extra cost to South Dakota. I know this is one that a lot of people care about, that they're really concerned about. I don't blame you. It eliminates SNAP-Ed, the program that funds SNAP-Ed. I'm going to get to that a little bit. There's still a sliver of hope in appropriations. And next slide, please. And then we have the citizen status for eligibility changes as well. One thing that is not direct in the reconciliation law that will have a downstream effect is these cuts to Medicaid and these cuts to SNAP will mean that fewer children will be participating in school meals. That's in states that haven't already adopted healthy school meals for all. And this is because of categorical eligibility. Basically, if a child their family signs up for SNAP or Medicaid, they automatically get school meals. And the data shows that when you get rid of categorical eligibility, or you get, not categorical eligibility, I am stumbling all over myself today. I apologize, trying to go too fast. When you get rid of the SNAP benefits and Medicaid benefits for the parents, there's less likelihood that they will take the time to sign up for, or adults, guardians will sign up for school meals for a variety of reasons. Miscommunication, when you're working 2 or 3 jobs to just try to keep your head afloat, sometimes things slip through the cracks. And so I'll make a plug. This is a really good case for increased adoption of healthy school meals for all. Next slide, please. All right, I keep referencing agriculture appropriation. So every year, Congress must pass their spending bills. There is a spending bill specifically for agriculture. It's a little bit of a misnomer because, as you can see, the majority of the spending, a little over half in agriculture appropriations, is for the Supplemental Nutrition Assistance Program. And the thing I want to point out in this chart here is the gray is mandatory spending, the green is discretionary spending. So this is why in reconciliation and things like the Farm Bill, there is the constant focus on trying to get cost savings from the Supplemental Nutrition Assistance Program. from the federal level. And next slide, please. And so we just had the House pass their agriculture appropriations bill a couple weeks ago, the Senate over the weekend. So that is hot off the presses. And because Congress has been, and I say this as a former Senate staffer, a little dysfunctional as of late, it's very difficult to get any sort of standalone bill passed. Usually it's only major reauthorizations for mandatory programs or appropriations. So we see a lot of legislating through appropriations, which as a purist, a parliamentarian purist, it drives me nuts, but this is the situation we are in. And so there are a lot of things called riders and report language. A rider is a policy in the appropriations bill to change the authorization. Report language isn't as hard and fast as a rider, but it kind of serves the same purpose. So these are some of the high level, I know I didn't capture them all, but the high level appropriations, riders or report language that we're seeing, what bill they were in. The thing I wanted to point to is the milk in WIC food package. The language basically says, hey, USDA, you got to change that. And one of the ways that with the new WIC food package that we're paying for the increase in fruits and vegetables and the cash value benefit is because less money is going to be spent on milk. And of course, the appropriators aren't actually giving more money to USDA. So USDA is going to be a little bit in a quandary there. I put in parentheses MLW, mildly less worse. So the Senate language, less worse. The House language is really, really bad about it. We have unlimited breakfast potatoes in schools, basically saying you don't need to serve another vegetable, you don't need to serve another fruit, you can just go straight to potatoes for breakfast, which potatoes are part of a balanced diet, but we know that previously the nutrition standards in school meals focused on other fruits and vegetables that had nutrients of need, nutrients of concern. And so this is why, and we also don't like the setting the stage that Congress can legislate what should be decided by nutrition experts. That's kind of where the peanut allergy and WIC food package on this is, prohibiting progress on definition of healthy. The only language around dietary guidelines for Americans is around alcohol. And I think the reason why Congress didn't dive more into that is because you have the MAHA Commission and Secretary Kennedy saying, we're going to overhaul the DGAs and we're going to put out something more consumer friendly, and here we go. What's not in the things that we were looking at that could have been in that aren't is cheese carve out. Basically, it was language that was in previous appropriations that we managed to take out at last minute that would say cheese doesn't count against these sodium standards in school meals. Cheese can be exempt from that. And looking at the data, if you do that, then it is possible that sodium levels in school meals would have been higher before we even got the updated nutrition standards in 2012. The whole milk in schools bill is not in the bill again this year. And I think that is because they have hope that the bill will pass on its own. You do not have Senator Debbie Stabenow, who was former chair/ranking of Senate Agriculture Committee, serving as a backstop. Interestingly enough, couldn't find anything on front of pack in there, and then nothing on SNAP restrictions. There was last year, and I think this is because, again, we're seeing the administration and HHS and USDA saying, yes, we'll address this, we'll do this, and you do have states submitting waivers around this. So I think that's why we're not seeing that in appropriations. The bills are pretty different in some regard, and so they're going to have to sit down and iron out a compromise, if at all. If I were a betting woman, I would say they don't actually get a standalone bill done, and they do what's called a continuing resolution and basically just fund the government at levels set the previous year. All right, next slide, please. All right, this is my little, nudge, nudge, wink, wink. Does the right hand know what the left hand is doing and vice versa? Because we're seeing a lot of mixed messages coming out of leadership in the House, leadership in the Senate, and the administration, and even between what the president is saying and the secretaries are saying. So here are just some examples here. And the one I wanted to point out is SNAP-Ed, because this is what we were talking about, what I said I would touch on earlier. So in the president's budget, they actually recommended increased funding for SNAP-Ed. And we know we just talked about reconciliation eliminates it. However, in the Senate appropriations bill, it gets its funding. And then in the House bill, it gets no funding, but down below, there are 2 sections in the House appropriations bill where they actually reference the program and things that these two policies need to, they need to integrate SNAP-Ed into whatever it is they're doing. So again, it's mixed messaging. It's not knowing what the right hand and left hand are doing. And it's also, you know, as we talk about the work of Make America Healthy Again, you need that nutrition education funding. And so I think in appropriations, this is where we can mitigate the damage of it being eliminated through reconciliation and hopefully just get it back into our funding streams. All right, next slide, please. I'm actually doing good on time. All right, Farm Bill. All right, so we have this thing called the Farm Bill. It's supposed to be done every 5 years. It expired in 2023. So we're way overdue. And this is my 5th Farm Bill I've done. And I'll just say unprecedented times remain unprecedented. I've never seen a Farm Bill just kind of collapse like this has the past few years. So it's a little bit of a misnomer, and I'll get into that again, just like agriculture appropriation. So the Farm Bill gets tricky this year, more tricky than normal, because you had the success of those who wanted to cut SNAP. They had success in reconciliation to do that work that they've been trying to do in the Farm Bill for the past 2 or 3 years. But to get a Farm Bill passed in the Senate, you have to have bipartisan support. You have to have that 60-vote hypermajority. And you are not going to get that unless you put those SNAP cuts, unless you fix them in the Farm Bill. But they have to pass something, because although they did like a little skinny Farm Bill in reconciliation, there's still some things that absolutely have to be addressed by the end of the calendar year. So we have an extension through September 30th. I'll get in a little bit why it's by the end of the calendar year and not September 30th of this year. Next slide, please. All right, told you calling it a Farm Bill is a misnomer. So you have 12 titles. Title 4 is the nutrition title. That's the title we predominantly care about. And next slide, please. These are all the programs that are in Title 4. And next slide. And I don't know, I was playing around with graphics. I'm pretty proud of that little, you know, first place ribbon. Slides in PowerPoint are not my forte. So, but everyone applaud my first place ribbon there. Jokes aside, Title 4 takes up about 80% of the entire Farm Bill. Now that number might change, will probably change as the Farm Bill programs are rescored based on the changes in reconciliation. So this is pre-reconciliation. So again, as I talked about appropriations and how much of the spending in the agriculture bill is towards SNAP, the overwhelming majority of spending in the Farm Bill is also SNAP. Next slide, please. All right, so I know I'm preaching to a choir here, but I like going through these slides and why SNAP is so important and why these cuts in reconciliation are going to be even more devastating. This is a real world example of an elderly woman that lives in my condo building. I help her with her grocery shopping sometimes, drive her places. So prior to the COVID bump ups expiring, February 2023, she got $275 in SNAP benefits. She's on a fixed income. She worked 55 years of her life, started working when she was 5 years old. Anyway, so, you know, it's, you know, we got to take care of our elderly, but instead, next slide, please. The next month, her benefit went down $23. I live in Arlington, Virginia. So next slide, please. I did the math a little bit ago. This was April of this year. I did chicken breast, lean protein, right? Everyone needs protein to be healthy. And so I went through the math And at that time in April 2025, a cost of chicken breast per pound in my neighborhood, the average was $5.60. I am fortunate we do not live in a food desert or food apartheid. I have 3 grocery stores within walking distance and more within a 2-mile radius. So we are lucky. Average size of chicken breast in our area is 0.357 pounds. I rounded it up to half a pound for the sake of simplicity. We went with 30 days in a month for sake of simplicity. So basically it would cost this woman $83.98 a month to have 1 daily serving of lean protein. She's getting $23 on her SNAP. And that doesn't even include fruits and vegetables or dairy or anything else she needs to purchase. Thankfully, she received Senior Farmers Market program. And in Arlington, Virginia, we have double up with it. So she gets $100 of farmers market spending bucks in the summer, which is great, but that's nowhere near enough that she needs. For her, she is clever, she is smart, she figures out a way to do that, but not everyone has that sort of time, or she worked in retail for 50 years, so she really knows how to game the system, if you will. Not everybody has that knowledge. Not everyone can do that. Next slide, please. So what happens if the Farm Bill expires again? And this is why we continue to have the drama, even though there was a skinny Farm Bill in reconciliation. These are the big picture items that are in the Farm Bill. SNAP is a mandatory program. It gets funded based on an economic formulary. It does not have to have a reauthorization. Kind of like school meals are the reauthorization, the authorization of school meals expired 10 years ago. Well, school meals are still getting funded, right? And that's because it's a mandatory program. But price supports, that's basically subsidies. And those revert down to 1949 levels on the calendar year. So the way that they go out is based on the calendar year, not the authorization. And so that's when, and so if that happens, we could see a massive collapse of the global food system. And so that is why it continues to be drama. It's going to be at the end of this year, who caves first? Do the Dems cave to ensure that our food system doesn't collapse, even though they might not get some of the SNAP provisions back that were in reconciliation? Do Republicans collapse first because they realize they don't want to be at fault for the collapse of the food system? I don't know. I don't have the answer to that. Unprecedented times remain unprecedented. And with that, next slide, I believe that was my last. That is my email. I know I just blew through a lot of information. Your head is probably spinning. My head spins every day. I get it. So always feel free to reach out with any questions. Like I said, I will have this slideshow available. Unfortunately, I have to drop off in a few minutes here, so I can't stay on and answer a bunch of questions, but I can stay on for about 5 minutes and answer in the chat. So, and we did have one question: where is food waste addressed in the Farm Bill, past or future? That is a good question. I forget which title it's under, but it's not under Title IV. And there have been some pilot programs and some initiatives by USDA to address it. I'm not sure where those stand right now. I would need to dig in a little bit.
Thanks, Kristy. First and foremost, I'm always inspired and mesmerized listening to you and how you are able to keep all of that honestly on track and understanding, and still simplifying it enough that we can grab it on the ground on the front lines. Because I know watching the federal team and how they work, to your point, it is truly, not to use buzzwords, but unprecedented times that we've never seen before. So grateful for your guidance, your education, and your leadership in this space and helping us along. You have a partner in the South Dakota Healthy Nutrition Collaborative. So we're here to move the needle on this work. So again, thank you so much for taking the time. Now I'll turn it over to Stacy Adnak, who is again very proud to work alongside her as one of our steering committee members. So over to you, Stacy.
Well, it helps if I unmute. Thank you, Tony. Thank you, everybody, for joining us today. I have the privilege to moderate our Vision to Impact panel discussion here. What a lineup of people we're hearing from today, and you're going to be just as impressed with our next individuals. I'm going to take just a moment to introduce each one of them. We'll give them a few minutes to present to you, share a little bit about their work before we get into some panel discussions. As we're working through this process, if you have questions, comments you want to add to the conversation, please use the chat or the Q&A so that we can incorporate your voice as well into the presentation. So I'm going to start with Tamara Baker. Tamara is the Project and Communications Director for the Carolina Hunger Initiative. She leads the summer and after-school nutrition work and the federal SNAP education grant in North Carolina. Her career began in Washington, D.C. as a press secretary for a member of the Ag Committee in Congress. I'm sure she'd have a lot to say about what's going on right now. She has worked with the USDA and Feed the Children. Chris Schwartz is the executive director of the Iowa Food System Coalition. I'm not going to lie, we've had a little bit of a crush on that coalition as we've been forming our own, and is serving a second term as a Black Hawk County supervisor. He is a lifelong Iowan and activist and has championed causes such as public health, water quality, and renewable energy. Chris has worked with Americans for Democratic Action for 18 years. Ann Palmer rounds out our panelists. She is a senior scientist at the Johns Hopkins Bloomberg School of Public Health and director of practice at the Center for a Livable Future. She leads the Food Policy Networks project and researches food retail, supply chains, food systems governance, and community engagement. Ann previously spent 13 years developing public health campaigns in Asia. So pretty impressive lineup here that, you know, as nutrition leaders, we're working to reimagine what's possible. We're looking at how to fight hunger, how to provide access to food in new ways that transforms communities. And collaboration is a really big part of that. And so I'm excited to hear about how this visionary thinking transforms the vision into action. So Tamara, we're going to start with you.
Great, thank you. I am here to share about our work. We formed 15 years ago as No Kid Hungry, North Carolina. Most of you probably heard of No Kid Hungry. We began and then later in North Carolina, as the pandemic began, we embraced a new name, the Carolina Hunger Initiative, to encompass our broader scope of projects. Still, we are No Kid Hungry North Carolina, but we have a new name that's broader. Our team of 9 professionals and many interns, as many as 40 at a time, focus mostly on the federal child nutrition programs, including school meals and summer nutrition, and more recently on college hunger. 1 in 5 North Carolina children are at risk of not knowing where their next meal is coming from, so it's a really big undertaking. Interesting fact, did you know there are 16 federal nutrition programs that collectively support 90% of our nation's nutrition provided to low-resource communities and families? Only 10% is supported by donated foods from food pantries and other donor-supported entities, which is part of the reason we focus so much on the federal programs. We collaborate and partner with state agencies, school systems, community organizations, and more to expand access to healthy meals year-round for all North Carolinians. We're based at the UNC, University of North Carolina in Chapel Hill, Center for Health Promotion and Disease Prevention, which means we are connected to, shout out to, number 1, UNC Gilling School of Public Health. This academic home allows a deep connection to research and analysis, to many students, and to considerable talent. Next slide. Here is the representation of our work. We're funded through grants. We could not exist if it wasn't for funding. A lot of people think you're at the university, so you must have a great benefit directly from the university, and that's not really the way it works. Our foundational funding is SNAP-Ed, a federal program administered by, in North Carolina, by the North Carolina Department of Health and Human Services, or DHHS. It has allowed us to work on increasing access to healthy foods through the child nutrition programs, using policy systems, environmental or PSE changes in nutrition education. Our Nutrition Ed focuses on pre-K through 5th graders, in-person classes, fun activities at summer meal sites with kids, and online adult cooking classes. But as you heard from Kristy, and many of us are beginning to feel deeply, the reconciliation budget bill just passed and now made law does not include any funding for SNAP-Ed. That in North Carolina is a loss of $11 million there and very critical services. So SNAP-Ed, our number has been our primary funding, and we will be looking to fill that void significantly. Expanding participation in school breakfast and summer nutrition programs is our daily focus throughout most of our work, including our partnership with No Kid Hungry. We're thrilled about that continuing partnership. It is a private connection, so therefore it's not in that federal realm of funding. We became part of the leadership team for a new effort a couple of years ago called School Meals for All North Carolina. And thank you for that shout out also from Kristy for that initiative. It's been kind of slow progress, but we have been able to secure permanent funding through our state legislature for the reduced price copay for school lunch. So now, effectively, if you qualify for free and reduced price meals, you actually get free lunch regardless. Already, we had the permanent reduced price copay for breakfast in place. We invite others to join the coalition at the school meals for school meals at no cost to families. And it is a broad coalition and growing. We know that school meals are an important part of the instructional day. A newer focus for us is the federal SNAP outreach program. And we hope to remove barriers to all North Carolina college students who need food assistance through SNAP with that program. We've created a website. The URL is here, nccollegefoodbenefits.org. And our research shows that 20% of the students in our own backyard at UNC Chapel Hill consider themselves as food insecure. And a recent GAO report shows that 2/3 of students likely eligible for SNAP do not receive them. So we're working to improve that and the whole atmosphere around college hunger. Our newest project has been to serve as the communications partner, again, to NCDHHS on its year 2 rollout of the 2025 Sunbucks program. This provides grocery buying benefits to families of $120 per eligible child. The program sent $131 million in benefits to North Carolina families in 2024, and we are on track for that number to even increase this year. Those are direct dollars into pockets that are spent in local grocery stores. It does require a match for administrative costs of about $6 million, but our state legislature did not include that in the 2026 budget. So therefore, we are really struggling to figure out if this program is going to be able to continue. We partner, fortunately, with our education agency, the North Carolina Department of Public Instruction, to co-promote all 3 of the Sun Summer Nutrition programs, one of which includes Sunbucks. I'm going to talk about the others in a minute. And an important thing that we do also is to host an annual convening, kind of like what you're doing today. Ours has been in person, fortunately, except for through the pandemic. We gather about 400 people together for an all-day event. It's called the North Carolina Child Hunger Leaders Conference, and we make sure that they have a special day of celebration and focus on all these topics that we care about. And we do this at a very, very minimal cost for them. So it's a very special day. You can go to our website at thecarolinahungerinitiative.org and learn more about this level of convening, which is so important to our statewide collaboration. Our next slide, please. Information is a critical advocacy tool. Again, we're at the university where we have access to a lot of talent, but this is just a quick snapshot to show you several things that are important about our state. We've heard again and again, if it's not measured, it didn't happen. So we are fortunate that we have this great partnership with the state agency. They share their data with us, and they rely on us to repackage it in a form that can be easily understood. We create what we call these one-page profiles, one-page front and back, for every year for each of the North Carolina counties. And we create this statewide profile. And it shows how the program works, the impact locally, and most importantly, it shows the economics of the program. Because when people really start paying attention when you understand the amount of dollars. But an important number to think about this is that we have almost 1 million, or 70% of our students in our North Carolina public schools are eligible for the measurements called for free and reduced price school meals. But as I said, all meals are free. So that's an astounding number. The number is even greater now. That was from the 2023-24 school year. And think about how summer, the hungriest time of the year, the benefits coming into the state, more than that million kids, 1.1 million actually receive benefits for Sunbucks. So the number, this is not even the final number. The final numbers were 131 million that came in from 2024 for Sunbucks. And for Sun Meals, which is the traditional way of serving meals at meal sites, the state brought in a little over 3 million and served over 3 million kids and brought in almost over 13 million. And then for Sun Meals to Go, which is the newest non-congregate program last year, it brought in 3.82 million. That's where meals can be picked up by families and in some cases delivered to homes. And that's a huge focus of ours, where we work on providing one-on-one connections and technical assistance to grow that program. Next slide. Communications is really a critical service we provide as well, and we want to make sure that information is shared broadly. We're going to see the slide so you can see the finite details about these programs, but we work on creating a brand, we have a website that we run for the North Carolina Department of Public Instruction called summermealsfornckids.org. And that's where families can find meals, where sponsors can find information about how to run their campaigns more effectively. They have marketing tools. We co-host a really fun training every year for all of the meal sponsors for summer meals. And we do that in November so that we can celebrate them and, very importantly, give them all the great tips for running a more effective program in the next year. And we also are fortunate that we rely on a lot of college students to help us with this summer work, in addition to the other work that we do. Next slide. And I know we're tight on time, but as we close, I want to give a huge shout out to all the hunger heroes on this call. All of us are stretched financially and personally. Let's look for ways always to uplift and recognize each other. We invite you to connect with us and join our collaboration. There's my contact information, and in red are just 3 of the websites that we manage around the projects that we work on. We could not do the work we do without collaboration. You see that our small staff of 9 is constantly engaging on so many levels. We learned when we first began this work in the state of North Carolina, we decided that we were the new kids on the block. And that didn't mean that we were the cool hip kids. That meant that we had to listen. We had to learn from others. And we determined we'd reached a pretty big milestone when in our 10th year, we were approached by our largest food bank, who said, "We were really suspicious of you in the beginning. And then we learned that you bring something to the table that we don't. And that is a collaboration and ability to work across all geographical and political and all the different lines that we draw about where our organizations serve." And it is so important that we're fortunate to have built that trust over time. And we just wish you well with your collaboration in South Dakota. Thank you.
Okay, Chris, we're going to bounce it over to you.
All right. Well, good afternoon, everyone. It's really an honor to be here with you today. My name is Chris Schwartz. I am as said earlier, I'm the Executive Director of the Iowa Food System Coalition, as well as a County Supervisor here in Black Hawk County. Today, I'm going to try to talk a little bit about how the coalition came together and where we've grown since then. This effort really came out of the pandemic, highlighting the need for food systems work to be done in the state of Iowa again, but comes off of decades and decades of really grassroots activism around the local and regional food systems movement. And so we can move to the next slide, please. The vision of the Iowa Food System Coalition is an Iowa food system that cultivates health, justice, and sustainability for all people communities, and the environment, centering local and regional food as a major part of the solution. We can move to the next slide. And so out of a handful of discussions of longtime food systems leaders in the state during the pandemic, they started meeting and decided that we needed to develop a food system plan for the state of Iowa. And that plan was developed with all sorts of collaborative and input meetings held all across the state, I believe scores of them, and culminated in the drafting and then the releasing of our food system plan, setting the table for all Iowans, which we released of July of just this last year. We can move to the next chapter or the next page. And so that food system plan, it's a 215-page document that is divided into these 9 different priority areas that really lays out what we think needs to happen in the state of Iowa over the course of the next 10 years or so. And so the first one of those is land and resource access. Food, and then the next is food and farm business development, working with food hubs and local retailers, people that are doing value added things on their farm. Farm and food system infrastructure, all the infrastructure that we need to have a local and regional food system. Local food and purchasing and procurement, that works with all of our institutional buyers, helping connect them with local foods and building the strategies to expand that work. Food, nutrition, and health, that gets into everything from all the health inequities that we're facing in the state of Iowa, as well as the hunger access or the hunger crisis that we are also facing across the country. Labor equity is a chapter that deals with the rights of the workers within the food system, everything from our farm workers on the fields to the many meat processing plants in the state of Iowa. Environmental stewardship, of course, deals with the environmental impact that our agricultural system has in the state of Iowa, especially water quality is a huge issue for us right now. We've got, I believe, the highest percentage of impaired bodies of water in the state, and just most recently, our largest city, Des Moines, our capital, had to, for the first time ever, institute, watering bans, and not because there was a water shortage. It was because the nitrate removal processing facility in Des Moines could not keep up with the amount of nitrates that they were having to remove. And so they had to reduce water usage. And this is the world's largest nitrate reduction removal system, and it still couldn't keep up. And so it's a serious and growing issue. Communication education deals with how we connect the public and with our goals within the food system. And then the next is local food policy. And I'll mention that all of these chapters are aligned within a priority team within the coalition that is actively meeting and actively collaborating around the goals laid out in that plan. And I say the last here, local food policy, that is our priority team that really deals with educating policymakers, planning our lobbying days, setting legislative agendas, both federally and state. And now we're starting to get into local. So we move on to the next. And so some of the ways, just in these last couple of years, that we've been able to help our partners within the coalition, which now number, as of yesterday, at 51 different partner organizations, including academics, farm operations, food hubs, value chain coordinators, restaurateurs, you name it, all sorts, and food banks and pantries, of course. And so some of the ways we help our partners stay connected, as I mentioned, we have those 9 priority teams that people are actively meeting and sharing their work, collectively applying on grants, looking for funding to fund different aspects of what they're doing. We have a monthly newsletter, We do lots of advocacy trainings, both online and in person. We work on collective funding efforts, and so the coalition serves as a hub, especially in this latest round of USDA funding opportunities. We really facilitated a lot of cross collaborations to try and submit, much stronger proposals. We really specialize a lot in media relations. We have a communications team at the coalition, and we've been, really successful in our reach. When things like the elimination of the LFPA and Farm for Schools programs came, we were right there out of the gate with many coalition partners, from the Iowa Farmers Union to food hubs to food pantries. It makes that we're going to be suffering from the elimination of these programs. And we really helped define the narrative, both in the state and nationally, because of our quick and rapid media work. We help to secure legislative victories even in these hard times. We help our coalition partners tell their stories and tell the stories of their people. We launched a podcast this last year called the Iowa Farm Table, which is released every other Monday. That's our edited audio podcast. And then the opposite Mondays, I host our live version, which is called Side Dish. The coalition allows for all the shared expertise across the state to be connected. And in addition to all the advocacy trainings we also provide and facilitate organizational and skills sets trainings. For example, next week we've got 8 different coalition partners participating in direct major donor training, because we all know federal and state funding is iffy, and so we're looking for other venues. Next page, please. And so one thing that I really love is that we now host a local food policy summit every year. And this is where we finalize our legislative agenda, and we get a number of legislators to attend, sometimes to speak at. And we do this, we dovetail this off of the start of the annual Iowa Farmers Union conference. We'll do the next page. So just showing, this visualizes just the growth over the last year. The first photos from shortly before I started. I came on board with the coalition in April of 2024. And so this was our lobby day from 2024. And you see 2025, we had just a lot more people there and participating. And we didn't do just one lobby day this year. We did 2 full lobby days plus many individual visits throughout the legislative session. Next page. And so some of the legislative victories we have been able to get done, and I won't say, we've had some losses. We haven't been able to get the state to fund double up food bucks the way that they should be. We haven't, we became the first state to go for these exemptions in school nutrition standards, which we're very concerned about, and didn't accept summer EBT program. But we still, even in that environment, managed to get a legislative win. This was the first time the state of Iowa directly invested in the purchasing of local foods. And this was started, we got a pilot program passed in 2024 that provided $300,000. Of course, this is a drop in the bucket to the millions of dollars we lost to the LFPA and Farm for Schools. But to allow food banks and pantries to purchase local produce, meat and dairy from Iowa farmers in food hubs to serve. And it's also provided only $75K for schools, because again, they've got a whole other agenda for school lunch in the state of Iowa. But we managed to take that from being a pilot program to in the legislature. We didn't get an increase in the funding, but we were able to make it a permanent program going forward. So we at least have that foothold in the budget from which now we can keep trying to build on, especially as the tides change. Next page. As I mentioned, we've got the Iowa Farm Table podcast. It's really excellent. It's hosted by our communications contractor, who's Beth Hoffman, who is a longtime food and food systems journalist. has been an academic, as well as the author of Bet the Farm, the Dollars and Cents of Farming in America. But she's the host for our podcast and is really excellent. So you can subscribe there. And if you follow us on Substack or Spotify, Apple, wherever you listen to podcasts, you can find us. Then we go to the next page. And so this is one of the initiatives we've got going right now in the light of losing Farm for Schools and local food purchasing. We're trying to drive up consumer demand for local foods across the state. And so this is, we're getting folks to take the Iowa local food promise and pledge what percentage of their groceries they can spend weekly on local foods. And this is in an effort to continue to support our food hubs and local food farmers so that they are still able to support pantries and food banks alike. Next page. All right, I think that's everything. I will turn everything back over to you, Stacy. Thank you.
I took a whole lot of notes. Thank you very much. And we're going to pass it over to you to talk a little bit about the work you're doing.
Thanks, Stacy. It's really an honor to be with you all here today. I was really excited when Jennifer contacted me. I too have deep roots in the Midwest, spent a lot of years in Minnesota and Iowa. So I was really excited to hear about all the work that's happening in South Dakota. So I'm at the Center for Livable Future, which is a center within the Bloomberg School of Public Health. Our center has been around since 1996, and we focus on food, agriculture, public health, and the environment, and where those issues intersect. And we do it through research, education, and practice. And so the project I'm going to talk about today falls into our practice category. We've been hosting a project called Food Policy Network since 2013, and the goal of that project is to build the capacity of food policy councils around the country and allied groups, other groups that are participating. We have, like a specific definition, but we really keep it pretty broad because the idea is to get people from diverse sectors that wouldn't typically be working together to come together and find a common agenda. So what does the Food Policy Networks project do? In many ways, it's a network of networks. So the work I'm going to be talking about isn't my work directly. I have worked with, I've been part of the Maryland Food Policy Council. It's called the Maryland Food System Resiliency Council for 3 years, and also with the Baltimore. So I have some experience directly with that. But what I'll be talking about is actually a survey that we conduct. And it's really to give you a sense of like the work that's happening across the country at the state level. And I kind of picked some different examples of what I thought might be of interest. So this data is actually from 2023. We will be in the next couple weeks sending out another survey. We do it about every 18 months to 2 years. It's going to be 2 years this time around. There are about 330 plus food policy councils around the country right now, according to our count, and about 12% of those are operating at the state level. So it's quite an endeavor. We get about 2/3 of the folks to complete the survey, and the rest of them we kind of sleuth. So just keep in mind when we're responding, we don't have everybody's responses, and we would love to have more. I kind of cherry picked the ones that I thought would be of interest to you. So the first group I'm going to talk about is Alaska. And Alaska's been around for a number of years. They are their own nonprofit organization, so it's the Alaska Food Policy Council. In terms of what they've done from a policy perspective and how they work with government, and also with academic institutions, I think it's important to kind of point out what role those academic institutions can play as partners in this space. So they worked with the University of Alaska to co-author and publish a report, the Governor's Food Security and Independence Food Task Force Report in 2023 and 2024. It gets used by legislators, by nonprofits, and other businesses. Their role is, as the council, is to provide recommendations to the governor, specifically on food security, but they also look at it from a local food economy's perspective and reducing the state's dependence on external food and supply chains. As you can imagine, Alaska and Hawaii have some pretty unique issues that they're dealing with because so much of their food is coming from external sources. So both of those states tend to be thinking about how do they build resilience and support more of their local food producers. So the report also summarizes the task force priorities, and they focused on institutional food procurement, barriers to producers accessing markets, wild foods, disaster response, and research needs. So it is, even though it's food security and it's like, definitely got a big nutritional component, it also is much broader than that. It takes into account a lot of the issues that they're dealing with at the state level. Then I'm going to talk about New Hampshire. New Hampshire, the Food Access Coalition is actually a project of another nonprofit. That's a very popular structure and governance structure that groups have been, more and more groups I think are leaning towards that, so they don't have to go through the paperwork of becoming their own nonprofit, but they're able to accept funds. They have been advocating pretty regularly for a lot of federal programs and enhancing those in their own state. So in this particular, in 2023, they advocated for a bill to reestablish the WIC Farmers Market Nutrition Program in the state and supported a program change to increase SNAP eligibility from 130%, which is what the federal requirements is, to 200% of the federal poverty level. So there are, at least in 2023, there are tweaks and things that can be done at the state level to help and improve what we're able to do with federal dollars, federal nutrition dollars. I think, listening to Kristy was pretty sobering in terms of like where we are now. So it's hard to say what that will look like, but this is what they were doing. I'll be very curious to see how groups are reacting in this year. And then the other two groups I'm going to talk about would be described more as conveners. And I bring them up, and we can describe conveners as groups that are bringing together local food policy councils across the state. In most cases, they're not working, they're doing it with the idea of building the capacity at that local level, but they also kind of have this bigger vision of what they want the state to be considering for food policy and agricultural policy. And so they do it in various ways. So North Carolina Local Food Council, their mission is to convene state and local food system leaders from cross-sector organizations. And they do it using a collaborative systems approach by kind of providing educational opportunities, research, and then other resource-based tools that are really helping them fulfill their goals of creating a healthy, more equitable food system. And so they have working groups, as a lot of groups do, and their food recovery working group wrote a standard operating procedures for the rescue and donation of prepared unserved foods that was disseminated to local health departments across the state. So it's a great way to do a policy that isn't require legislative action, but actually has a pretty big impact on types of foods that people are able to get. And then the last example I'm going to talk about is the Oregon Community Food Systems Network. That's actually a project that's been out of Extension, Oregon State University. And they do, much like Chris was describing, they have like an advocacy day at the State House. They do a lot of training around advocacy for their partner organizations. Last time I talked to them, I think they had like 50 or 60 different organizations that work on food system issues. That could have been grown since then. And they actually they have a food policy tracker. So all the partner organizations submit the information of like the bills that they're watching. People are able to advocate on behalf of bills outside of the ones that are in their organization. But it's putting out, a lot of information and giving people options and seeing all the action that's happening and the policy actions that's happening at that state level. And so one of the examples that they did is they tried to establish a program in the Oregon Department of Human Services to provide nutrition assistance to all residents regardless of immigration status. And then they also sought funding for Double Up Food Bucks. I don't think they were successful this time around, Chris, either. So you're good company. It usually takes a few years. But that's just to give you kind of a bird's eye view of some of the things that we're seeing going on around the country. And I'll stop there.
And that's really great. And hear some just commonalities resonating from all three of you in information that you've shared and ways in which work is being done in your states. And so I have several questions for each of you, but we're going to narrow it down and give each of you one question to start to kind of manage this discussion just a little bit, and we'll see what we have for time. I'm going to start, Tamara, with you and ask, as a new collaborative here in South Dakota, you know, Jennifer shared how through our goal groups and our structure, we've been working on the work in which we do and where do we focus our time. And policy becomes a really interesting topic for us because there's a variety of stakeholders within the collaborative, as there are in many. So can you share a little bit about how you keep diverse stakeholders aligned and motivated, especially when it comes to every member having different types of priorities and levels of capacity? You know, we've talked about a little bit, you know, some have organizations that have staff that can go out and advocate or hire lobbyists, where some are a one-person show, just trying to do as much work as they can. So how do you keep that cohesiveness within that group and keep them moving toward the same vision?
Thank you, Stacy. That's a great question. We really start from the premise that people need to be informed. And so we have a really strong communications base, so that we, as a matter of fact, half of our staff are communications professionals. And so we make sure that we have a really robust mailing list that we slice and dice so that we know when we need to talk to superintendents. By the way, we have to 60% open rates for the school superintendents. We speak to principals. We speak to teachers. We treat them differently. We very much cater a message to what they need to know, and we try to make sure we give them action items, and then we track those action items so we can see when they go to that web page and how long they linger and what is it that seem to appeal to them. We don't treat the state as a whole on advocacy, except under our School Meals for All North Carolina program. Now, you saw from our slide that we work on about 9 different projects, and they weren't even all depicted there. So we have a staff of 9, so we just can't have, and we all work across the program, so we just can't, we can't be all things at once, but we make sure that, so for instance, I guess the best example is talking through the coalition collaboration that we have with School Meals for All. And that is, there are 4 groups that are on the leadership team, and we make decisions together as a leadership team, and then we take those decisions out to the coalition members, and we make sure that there's communication that goes to them every single week about the status of things and what very specifically what action they need to take that week, what groups they can join, to how we can recruit students to be ambassadors talking on the behalf, what groups they can join, where town hall meetings are being held, where fundraising events are being held. But I guess the common thread of all that is just really strong communications and specifying those where needed and tailoring that message to the individual group.
I promise that was not a preloaded question from a VP of public relations. I did not know that was the direction she was going to go. So thank you very much, Anne. Chris, I'm actually going to ask you a question that came through our Q&A here as you were sharing. Would love to hear more on the advocacy trainings. What does this look like? And was this for preparing for lobby days, grassroots outreaches, applying for aid? What was the purpose of those advocacy trainings?
Yeah, so it's been kind of all of the above. We've done, so for folks, as we were preparing for our first lobby day of the session, we held a series of 3 trainings. All to, one part of it was just delving in to what the actual policy was, so people understood what we were asking for. But then the others, we then in the second session, they would break out, into breakout sessions and practice talking to a legislator. And so I'd put on my elected official hat and say, okay, let's practice, having this conversation. Let's get your elevator speech. And then a final one was just going over like the logistics of the day and what to really expect from, in Iowa, they don't have offices. They're all there in their chambers, and you're sending notes in to pull them out into the rotunda to talk to them. And so just walking people through all that. We also, one of my favorite things from being a longtime community organizer was bird dogging, and I was very good at it. I asked Barack Obama his very first question of his presidential campaign about obsolete Cold War weapons systems and how we could fund social services better. But that is essentially, training people how to be at a town hall or a candidate event and how to have that quick conversation or get that quick question in to get your point across. We also do letters to editor training, op-ed trainings, where we'll actually have folks come on and they'll write a letter to the editor that night. They're right within the training, so we know it's done and ready to go. And then, as I had mentioned before, we either do like more organizational trainings and skill sets like direct donor training and all that kind of stuff.
I'm going to piggyback on that, Chris, and just keep going with conversation a little bit here, because we know that the voices of people with lived experience is really important to this work. Not only for the collaborative to understand the way in which to drive the work within these groups, but also to help build understanding and share reality with people within our communities, whether it be people who are interested in the space of access to food and nutrition, or legislators, people who don't understand. Do you have some tips and tricks for incorporating those voices of lived experience into advocacy work?
Yeah, it's making sure that they already have a seat at the table within your organization and your coalition, and so that you're not just kind of tokenizing somebody's experience or exploiting it at the last minute, but they've actually been involved in what you're doing. That's to me is the most powerful. And so the lived experience voices that we specialize in at the coalition is one, the small family farmer voice, who's trying to do things right by the environment and by their community and provide healthy food to those who need it, as well as in some ways we're also a coalition of coalitions. So the Iowa Hunger Coalition is a part of our work, and they do a really excellent job of highlighting the lived experience voices. And so as much as we can, we just there act as the mechanism of we're going to connect to the reporters, we're going to connect you to the legislators, because that's what people want, whether they're a legislator, whether they're a reporter. People want those direct stories. And as soon as you can prove yourself that you are an asset because you can connect them to those stories, you're going to have that stronger relationship for years.
Excellent. And you have a bird's eye view of work that's happening through the survey and some of the outcomes that you see. Can you share a little bit about what is the key to truly making cross collaboration work in situations like this or in intended outcomes?
So there are probably multiple things that you kind of need to fall into place. I think sometimes groups will come to us and they'll say, we want to have a food policy council, and they'll say, why do you want a food policy council? And they're like, because kind of like everyone's doing it, or we want, it's like, this is an exciting thing to do. And I think, the intentions are great, and it's also a ton of work to do it well. And it's really important to take that seriously, because I think, you can get off on the wrong foot, or, that can cause some issues. So I think, Chris's comment about like making sure people are at the table when in the beginning, like we, recommend, I think that the people organizing it really make a concerted effort to develop relationships. If it's not with people directly affected by the problem that you are, or problems, that you are making a concerted effort to work with those organizations that are representing them. And then, it's harder to do it directly in a state level. I think that it's good to acknowledge that you're dealing with a much larger scale, but I think that's still really important. I think relationship building is probably the most important element that we have watched, and overcoming conflict and being able to work through issues when you have a good relationship with the people in your group that happens over time, it can make a huge difference. It is very hard to demonize people or demonize an issue or a position when you know that person personally, or you're eating at their farm, or you're, in their food pantry talking to them about their reality. So I think really we see, groups being able to come to agreements when they have those deep relationships. And it takes a long time to do that. And sometimes people don't want to spend that time. Not everybody is suited for this. I feel like there's a role for anybody who wants to participate in food systems work at whatever level, but it might not be sitting in meetings, right? It may be other ways to engage them and energize them. And I think the last thing I'll say is just like being, when people are starting groups, thinking about what you're asking of people who you want to participate, like really putting down, like what, here are the expectations, here's what we're looking for, here's why your participation is important, and this is what, and why we came to you. So it is a little bit of, being somewhat prescriptive at that point to have those conversations. And so those conversations happen before all the work starts even, that there's a real effort to do that. And, it's hard to do, it doesn't going to follow a linear pattern, but I think, ensuring that you have these kind of check boxes and, you're constantly kind of snowballing and building your network is important.
The work is never done.
Yeah.
Stacy, I might just add there that there's so many students who are interested in these topic areas and who have lived experience. And we've been really fortunate to find great contributors who also say, and I was that child, I was that student. And when they work on our causes on college hunger or school meals, it's a very different tone than it would have been otherwise.
I think you set me up really well, Tamara, for my question for you.
Okay.
I always find these panel discussions tend to go that way, but you've done a lot of really great things by bringing in some benefits for the state for access to food through some programming. But being from a food bank, we often say we have a need that we need to address now while building sustainability and changing things for the future. And so how do you balance that big picture vision with the immediate needs of the community and making sure that food access is still a priority?
Well, that's a good question. Sustainability, are you asking about how do we all sustain and still keep food access at the forefront? It became a lot easier during COVID. We all recognize that kids weren't getting fed if they didn't show up at school. We realized that if people couldn't show up at the places they normally did to get food, it was going to be a problem. And then I guess my deep concern was when people said, well, COVID's over. Why do you still need those programs? We needed those programs before COVID, and we need them even more so after COVID because prices have risen. And that is a reality, and that's not a political issue. Prices have risen and food is more expensive, and yet healthy foods are more important than ever. It is just doing the day-to-day work and trying to find unity, trying to find the bridge to work across the aisle, trying to find what appeals to others. I'm going to be in part of a press conference next week with a legislator who wants to exactly ask that same question. How do you still elevate it in these times? Because there's so much misinformation out there, but our need is not getting smaller. Our need is getting greater. And we know a lot, but we have to be able to build on our successes and just keep fighting the good fight.
You have energized me for another day. Thank you. We have just a few minutes left, and so I have one question I want to ask each of you to answer in about 1 minute. Okay, speed round. Here we go. in your experience and speaking to a collaborative that is a year old, I'm going to call us a baby collaborative. We're just getting started. We're not even really walking yet. What is one thing that you would like us as a collaborative to take away that you feel we should take action on in order to advance our mission to provide access to food and nutrition in the state? So 10 seconds to think on it. I'm up to like a 16-second pause, but I'm not good at it right now. And I am going to start with you, Anne.
Okay. I'm not sure I got the question right, but we'll see
Yeah.
what I can do. So if it was one thing, I think to keep in mind as you're moving forward, I would say policy takes a long time. And I feel like don't get discouraged that, I was really happy to see you had that whole bucket about a policy agenda and moving and like dunning the scan. You've done a lot of the work already that you need to do. Mm-hmm. So some of it is like, where are those policy windows that you can see are going to come up in the next year or could come up? And how do you kind of prep those issues? So if there's an opportunity, they're ready to go. So I think it is this kind of, that to me is like a big balancing act with policy work, is that it's, you never, like sometimes things just happen and they emerge and then you've got to be able to act. So it's like preparing the ground for that.
Great, thank you. Tamara, how about you?
Don't get caught up in the process.
Mm.
It is so easy to say, well, we have to do this and we have to have this organization and we have to have these goals and we have to have this structure and we have to do this and we have to do this. We bypassed all of that. And I know you all have done a great job and we simply said, let's get the people in the room and let's talk through these issues and let's see what their priorities are and let's see where we overlap. And that is a stance that we've taken in terms of bringing in so many organizations. And the second thing I'd say is celebrate every success of every organization and give them a chance to say, here's what we did that mattered. And here's why we're so proud of that work. And, we say this about like school cafeteria workers. The kids see them and love them every day, and yet they have no voice to the public. And so we give them a voice and we give them the accolades and the attribution, and it is paid off in spades. It's just paid off so much.
That's great. That's really good advice. Thank you. All right, Chris, we're going to round it out with you.
All right. I want to highlight that celebration part a little bit too, because one of the core principles of the coalition that you have to agree to join is to embrace a culture of celebration. And that's whether it's in the legislature, whether it's just a new organizational partner, whether it's a really successful media run, something like that. You need to celebrate it all. And here, since we emphasize local and regional foods, we have to celebrate with really excellent food. But the other part I would say is have those policy conversations. Don't wait to have them. You can have them all throughout the year. In Iowa, we have a part-time legislature, and so they've got a whole big bunch of the year that some of them aren't doing very much. And so you can you can have those conversations anytime.
That's really great. I love the culture of celebration idea, especially in the environment that it's been lately where we're all feeling a little discouraged and run down. I think you're right. It's really important to lift up all the wins, regardless of how big or small that they feel. So, well, thank you, each one of you, for joining us today. We really appreciate sharing the work that you're doing and the insights on how we can continue to move forward as a collaborative. And we've got another year to go here, and I can't wait to see where we're at. And we appreciate the guidance that you have provided us to get through that. For everybody who's attending, we are going to take a little bit of a break. Get up, stretch, get yourself a snack or some water, and we're going to reconvene here at 2:55, so just before 3 o'clock. And we're going to jump into our next panel discussion that's really going to focus on strengthening health through food access. So go ahead and take a little bit of a break. Thanks for joining us.
Okay, welcome back. I hope you all really enjoy the first panel session, and I hope it's also given you time to think about some ideas for our future. After this next panel, we will have just some brief time to get some input from you. But until then, I am going to pass it over to Dr. Renshaw, who's going to introduce our next panel. Dr. Renshaw?
Thank you, Jennifer. Wonderful to be with you all this afternoon. I've had the opportunity to work with some wonderful folks over this past year as we worked on the South Dakota Healthy Nutrition Collaborative. My passion for this endeavor has really been around how is food really being used as medicine, as Dr. Bastian made earlier comment on the kind of the pyramid of food as medicine. Is food not only has the ability to prevent disease, but actually put disease in remission and improve health outcomes. And a longtime legendary advocate of healthy nutrition and food as medicine was Ann Wigmore, who said that the food you eat can be either be the safest, most powerful form of medicine, or it can be the slowest form of poison. So today, I have the honor to work with some wonderful folks who've been sharing their work with health systems across the state of South Dakota. So it's my honor to introduce them today. So Lindsay Weber, she's the president and CEO of Avera St. Benedict's Health Center since 2022. She previously served as a hospitalist for Avera St. Benedict Health Center prior to her administrative role. She holds a Bachelor of Science in Nursing from South Dakota State University, a Master of Science in Nursing, family nurse practitioner from Clarkson College, as well as her Doctor of Nursing Practice and Systems and Organizational Leadership from the University of South Dakota. With a deep-rooted passion for serving rural communities, Lindsay brings a wealth of clinical expertise and executive leadership to her role. In addition to her work at Avera St. Benedict's, she contributes to serving her time in improving the health, serving in a multitude of boards within the Avera system, as well as the Parkston community. She's a wife and mom and enjoys spending her free time with her children and a multitude of activities throughout her community. Our next participant is Dr. Joseph Seslin. He's the Vice President, Medical Officer, Sanford Children's, and Vice President of Quality Safety at Sanford Sioux Falls Region. He's practiced pediatric clinical care at Sanford's Children's for over 25 years, and for the last 4 years have been focused on Sanford's commitment to high reliability. In 2003, he was initiated to start the Kids Kitchen food pantry, helping families in need without judgment with respect to dignity. The Kids Kitchen is participating with South Dakota and the Sanford Health Foundation, which currently distributes approximately 5,000 pounds of food and hygiene resources per week and serves populations at Sanford's Children's Specialty Clinic, Children's Voice, and inpatients of Children's Hospital. In 2024, the Kids Kitchen helped over 22,000 individuals. In May of 2025, the second Kids Kitchen began to serve the needs of maternal health, primary pediatric patients, and women's health. And all voluntary group sustains and contributes their time to the Kids Kitchen program, and it has served as a model for other programs throughout the Sanford system. Our last guest is Ann Wenham. She is the Community Engagement and Government Affairs Manager at Monument Health, a community-based health system which is headquartered in Rapid City, South Dakota. Monument serves over 20 communities across South Dakota and eastern Wyoming, offering care in 33 medical specialties through 5 hospitals, 8 specialty and surgical centers, and more than 40 clinics and clinical centers, and oversees community giving and engagement initiatives, including a program that provides over 22,000 free health screenings annually to promote preventative care, enhance community well-being. She also leads the efforts to strengthen partnerships that address social determinants of health, including food and nutrition security, helping to bridge clinical care with community-based resources to improve health outcomes and reduce disparities. These folks have done tremendous work over their careers, so it's wonderful to have them on board today. So there's been a lot of activities with each one of your organizations. In addition, within your organizations and your roles, you really have unique demographic needs that are somewhat different depending on the geography and the population of the communities. So as we start this afternoon, I'm interested, and I'll start with you, Lindsay, is how is your health system integrating food insecurity screening into clinical workflows, and what partnerships or innovations have helped you connect patients to food resources? So I'll start with you, Lindsay.
Well, Dr. Renshaw, thanks for the introduction, and thank you all for having me today. It's really an honor and a privilege. I've learned a lot already just by listening to other folks across the United States talk about food insecurity. But in regards to your question and how we're really integrating this into our clinic, it's really become a hardwired workflow for our clinical staff. And I think first we have to recognize, as we've had lots of conversation about it, that food insecurity is a real need. And really integrating that into people's workflow and helping them understand the why as to what we're doing this for. You know, when we brought this to our staff, looking at social determinants of health and screening patients and really opening up that conversation with patients, I'll be honest, at first it was met with a little bit of resistance, and you know, it's one more thing that we're going to have to do in our clinic setting or in our 20-minute clinic appointment. But when you can connect it to the why and how it better serves our patients and helps with their health outcomes, it's really become integrated into our workflow. Our staff have embraced it. They see the impact that it's making on patients. And I think that's been a really important piece when we developed our local wellness pantry.
Thank you, Lindsay. Dr. Schlejon, how would you describe your work as an integrated delivery system, and how those partnerships or innovations are working for you in Sanford?
Yeah, thanks again for having me, and it's a privilege to be part of the collaborative. We've done the same thing, I would say, just as Lindsay. This has become a hardwired part of our practice. Every well child visit, every primary care visit, the annual visit, internal medicine visit, we screen for food insecurity. And, you know, just like we learned with mental health, if you screen for something, you need to know what to do if they screen positive. And so it's really been a concerted effort both across both in the metropolitan areas and in the rural areas to not only screen and have that conversation, but then also operationalize and be ready to assist people, particularly in the rural communities where the resources may be less numerous.
Very good. Anna, I'll turn to you. Interesting population. We know, those of us who live in the state, that some of the population that Monument serves is in real dire straits as far as their needs. So how's Monument looking at addressing some of these issues?
Sure. It's very similar to what both of the other individuals on this panel were talking about. But you're right. We do face different challenges on this side of the state. And so a lot of it comes down to really listening and being flexible and understanding what those changes are, what is happening. So we screen for social determinants of health during the admission process for every patient. And then that does include food insecurity. If that happens, it triggers then a resource referral in that after visit summary at discharge. We have case managers who are really key in making sure that we can then connect our patients to maybe something like Meals on Wheels if patients express interest in that. Or, for example, we have maternal child social workers, and that helps families connect with programs like WIC. And so we have case managers. We then have dietitians that work with different individuals. We have eating disorder clinics. We have our diabetes educators. It's really trying to figure out what our patients are dealing with, and then figuring out how we can fit that into all the different areas of specialties that we have.
Thank you, Anna. We talked about this earlier about when you're putting a program together, the importance of measuring outcomes and what kind of impact these programs are having. So how are you measuring success, and what metrics or stories do you rely on to assess the impact of these food and nutrition initiatives? Lindsay, I'll start with you.
You know, I think as we talked earlier, sometimes it's measuring the small successes first. So our wellness pantry has been operational since last November. And, you know, at first it was kind of like, gosh, are we getting enough fruits for our labor? However, I actually just before coming here today was visiting with some clinic nursing staff, and I said, just out of curiosity, how do you guys feel like the wellness pantry is going? And just right off the bat, I think we had 4 nurses who said, I had a patient who was struggling with their diabetic management. They couldn't afford their medications. However, they screened positive when we addressed food insecurity. We administered an emergency supply of food for them, and they said that really saved them enough money to purchase their prescription that month. That's where you're winning. They're able to now be more compliant with their medications for their diabetic management. We track our hemoglobin A1C goals as a quality measure for our clinic staff. We also track our hypertensive management. I'm happy to say that we are tracking very well in both of those factors, but it's those little things that help those individuals be successful. Giving them access to healthy food is really important to the management of their chronic disease, and that's what how we're measuring it, I guess. Of course, we're measuring how much food we're administering, how many patients we're screening, how many individuals are screening positive, and that's great to monitor and track that data. But the success comes when you're seeing the positive results in terms of health management.
Dr. Seslin, I'll turn to you. Any thoughts on how you guys are measuring those initiatives?
Yeah, we do those objective measures like Lindsay referred to, and we're real proud of both the number of patients we screen and also the number of patients that then accept resources. But I guess I'd like to talk about more of the softer things that are more difficult to measure. We had a 17-year-old emancipated minor who had not eaten for 2 days. We started our pantry, the Kids Kitchen started in 2023, and we quickly learned that if you are food insecure, you are also hygiene product insecure. And the emotion of giving a young woman a brush who has not had something to take care of her hair for months, those stories really impact. I'd also like to say that the impact on those, in our Kids Kitchen, it's all voluntary. The impact on the people that serve on it has really been interesting to me. It has inspired, it has brought us together. Every May we have a food and hygiene drive that gets quite competitive. That's been a lot of fun. We've also had significant amount of community support that have approached us, that have engaged with us, that really have embraced what we're trying to do. So it's those impacts as well. The other thing that we continue to try to figure out how to objectively put in a data point is that we think it has decreased our no-show rate. We believe that families have grown in their trust of us. They've grown in understanding that we are trying to deliver empathetic care. We are trying to do that in a non-biased, non-judgmental way with respect and with dignity. And I think it's established those relationships and have made it less transactional, if you will. And so those are all soft measurements, but I think they've been important, and we've been celebrating them and lifting them up.
Dr. Renshaw, we have a few questions in the chat. I don't know if you were able to look at those, but I've flagged them for you now.
I have figured it out, so thank you. And they're really good questions, so I do want to get back to Anna. I want to finish up with any thoughts from you on, again, how is Monument looking at measuring their success?
Certainly, all of us healthcare systems, Avera and Sanford and us as well, we do a community health needs assessment every couple of years. And so at Monument Health, that drives a lot of the work that we do. So that's a lot of that data-driven metric that we're looking at to see what is changing, what are those major focus areas that we need to be stepping up and helping in a really impactful way. And so that is one of those pieces that drive us from the top through all of our strategy that we're doing. But to echo what everyone else is saying, it's those stories that really, I think, make that impact and remind us that we're serving people and that we're not just serving numbers. And so we have a lot of numbers that we look at to see how we're doing, to see how we're connecting. But What we have been really working on is building trust. There's a lot of messages that people are being served from a lot of different sources. And so for us to be able to build up the trust with our community members is really important. And so for the past couple of years, we've focused on having a community health screening initiative where we provide various free health screenings out in the community. And some of that has been to provide free access to some of those health services. But really one piece of it is just to hear the stories of our community members, to see what they're really dealing with in their day-to-day life, and then being able to bring that back for us to make better decisions. And from year to year, we've been able to see repeat people come to different events that we're at and say, hey, last year I came and talked to a couple of nurses at this event. And because of that, I went and sought help, and now I have a primary care provider and XYZ. I'm doing so much better, and I'm grateful for this support. And so having those conversations and creating space for those conversations outside of the walls of our facilities have been really important for us.
Thank you, Anna. So I'm going to pivot back now because there are some excellent questions in here. There isn't a clinician who's part of this collaborative today doesn't know we're responsible to screen for just about everything. And it takes time, and there's a lot of process changes. So again, how long does your entire screening process take? I'm going to speak specifically to social determinants of health and maybe food insecurities. How often do you screen for these things? What type of technology may you be using? I'll let the panel decide on who'd like to take that first from an operational perspective.
I can take that. And I have a little bit about this in my presentation too, and I'm sure the others have, I'm not sure how our processes are similar or different, but at Parkston or across Severo, this has been integrated into every clinic visit that we're currently doing. So we screen for social determinants of health. We ask 2 different questions in terms of food insecurity. If patients answer that they are yes to either question, then we offer access to our wellness pantry or an emergency supply of food. It really takes our nursing staff. It's integrated in our intake process with our nursing staff. It takes them honestly about 10 seconds. When I asked them, they said it's really a very quick process. It's again, all integrated into our electronic medical record. So it's part of the patient's record. We can pull data from that. It really hasn't added a lot to their workflow, but it's been profoundly impactful in screening and opening up that conversation with patients. And it's been a fairly easy process to hardwire. We also screen all of our emergency room patients and our hospital inpatients as well upon admission.
Any differences, similarities, Dr. Seslon or Anna?
Yeah, not any differences. The only thing I would add is that in certain segments of a population, we now deploy electronically these screenings. And so essentially they are being screened before they walk into your clinic. So again, I don't think we've not really had any kind of an issue with this has added too much to our workflow. Now, when they screen positive, I think probably each of us have different operational individuals who then go in and address that, and that may take up more room, whether it's social work, case management on the inpatient side. I think we've all mentioned that there's a number of individuals who have that expertise to then address that food insecurity, whether it is if they're going to participate that day in the pantry, or if they need to be connected to resources in their hometown.
We're very, very similar. I think from our standpoint, one thing that pops into my head when talking about this is building out that resource database is something that sometimes can be challenging to make sure that we really understand the full scope of the services that are provided in our communities. The Black Hills, we're really fortunate in having a lot of wonderful collaboration that goes on out here. However, there's turnover at nonprofits, and there's different contacts, there's different phone numbers, maybe things change, maybe things don't. And so that's something that we're continuously looking at of how can we be better at making sure that we have a good handle and a good database on those resources. So then when our case managers are in those situations, it's easy for them to refer to the proper channel that that patient needs to go to.
One of the things that I don't think many folks might know who are not part of the clinical community here in South Dakota, with the Vera's transition to Epic, Monument already being there, Sanford already being there, these type of screens are literally going to live in the medical record. And again, in the Epic world, there's the ability to share this information as related to these insecurities. So again, electronically, this will be a powerful tool across the state to understand some of the data and some of the issues that we need to address as a state. Someone asked a really good question, and I might ask Dr. Sejla on this one. Is there any comparison? So the screening for this, the social determinants of health, is there any comparison against like a PHQ, a PSS3, or an AHQ with food insecurity? And I think, again, William, you can correct me, but I think of someone doing a PHQ, which we use for depression. Is there a higher relation in the PHQ screens with the social determinants of health, particularly related to food insecurity? Do they go hand in hand, or is there not much of a correlation?
I don't know that I know the answer to that. I guess I would answer it in two ways. One, we know certain populations have a high screening rate, and I will give an example of that in our Child's Voice community. Very often, these are families in crisis, and they screen quite high. And so, we have found that, but I don't know that I don't know that I could say we have a direct correlation to those who may screen high on a PHQ, that they also screen higher on food insecurity. I don't know that we've really looked at that either. I think that the corollary is that we have found that it has been a good lesson in bias insight. So for example, in our children's clinic, we screen on every visit. And it's been really a good lesson in, it really doesn't matter what kind of car you drive or how you are dressed. Individuals can screen positive for food insecurity. And I think that's been a good take home for our groups.
That leads me into an interesting question and a really good one. Removing the bias. So how do you folks make sure that when patients receive your food or these other types of gifts, I'm going to call them gifts, they're treated with dignity?
Well, I can say how we do this. They are screened behind closed doors. If they screen positive, the nurse calls one of our social workers and says they've screened positive. The social worker goes in and talks about, would you like to receive food today? Would you like to receive what kind of food? Hygiene products? Is there any birthdays or special events? We have kind of a special event pile as well. And then if they say yes to those, then we very discreetly, everything is in non-transparent bags. We have core members who then go get the food, and the food is then put on their way out. And so most families take about 50 pounds of food. We have frozen, we have fresh produce, hygiene products, but we do it, if a patient comes in weekly and they screen positive weekly, there is no one who questions that. It is without judgment. It is non-transactional. And that's kind of the way it works for us.
I would say Avera is very similar in that. Our process is that the nurses are screening, and if patients screen positive, the nurses are going to our wellness pantry, gathering the bags of food that are in a cloth bag, which is dignity preserving. The patients are then, that's brought to their clinic exam room, and then they leave the facility with the food. Very similar process, and maintaining dignity is certainly of the highest priority as well here, just to ensure that trust and that, we can open that trust up with our patients and community.
Anna, anything you want to share there?
Sure. So we don't have as large a pantries as Avera and Sanford do. We do have one in our family medical residency clinic. And so it's very similar in that sense. We do everything to try to make sure everybody feels comfortable and there is not, yes, and it's as anonymous as possible. Another thing that's really important to us is caregiver education, making sure that individuals that will be in contact with patients really understand bias, because many times we can step into bias non-intentionally just because we don't have that understanding. And so we work a lot on education of our caregivers to make sure that they can understand how others may be looking through a different lens than them, and they need to be culturally and I guess culturally sensitive to differences in all of our patients.
Pam asked a question, and it's a really good one, and I'm not going to go into the federal question yet, but when you talk about sustainability, how are your internal food pantries funded within your hospitals, especially, whether it's Monument, Sanford, Avera? As nonprofit system, we'd really like to understand the support from the larger medical providers. Would it be better to partner financially with nonprofits that we already are trying to address these food insecurity, or other entities? So it's, do you partner with I think the question is, are we partnering with the large health systems? Do we need to find other large nonprofits? Are there other options that you as health systems are looking at using to sustain your efforts?
At Avera, we're currently partnered with Feeding South Dakota, then Healthy Start grant programs, and that's system-wide. But in Parkston, we also have leveraged other local entities that have grant funding to help support our efforts. So we also do a produce prescription question here, sorry, I was reading the comment there, a produce prescription within every bag that we distribute. Every patient also receives $15. That's good for fresh or frozen fruits or vegetables at our local grocery store. And that program is funded through local grant funding, which will help ensure that sustainability going forward. It's a private grant fund that we applied for. We've also had conversations with the Avera Foundation to help offset the cost of this for sustainability in the future.
Yeah, I would say, we really value our relationship with Feeding South Dakota. We trust their leadership. We see their connection to purpose, and they are a valued partner. We leverage our Sanford Health Foundation in enabling community members, employees, families, whoever wants to contribute. And that has received a great deal of support, and that has really enabled us on the hygiene side. We have significant food drives, hygiene drives that have been well received. And all of that together is really our sustainability. The other thing that has surprised us, that has really been just a great way to continue the community support, is when you as my colleagues know, we don't want to spend money on non-food, non-hygiene. And so the cloth bags, believe it or not, become an issue. And so we've really had great community support with the cloth bags. It's been a way to bring communities into our clinics. It's been a way to involve them and engage them. And I think in doing so, raise awareness, because they always come and tour the kids' kitchen, and it really raises awareness that this exists here, this is a problem here, and we all have to participate together in how to address it.
For the clinic that we are, for our family medical residency clinic pantry, it's a combination of working with Feeding South Dakota, but then a lot of it is donations from our caregivers and physicians. So this has been something that came about because we saw such a need in it. And we have, healthcare in general has really passionate individuals that work for them. And so it's great to see when people come together, how they take care of our community outside of just in our hospitals and clinics. And we do outside of that, because that's only one clinic that we have access to when we serve a vast region. And so that's where it comes back to really building out those resources so we can empower our patients with tools. So when they face challenges, we don't just say, well, there's not much we can do to help you. We say, this is how we can connect you. We would like to get you in partnership with this entity or that organization. And so it's continuing for us to build those collaborations. We can't do it on our own. Hospitals and healthcare systems can't do it on our own. And so we really have to come alongside those other entities that are taking care of our patients out in the community, because together, that's how we're going to be able to help them. Like Secretary Matt said earlier, 20%, I think she said, of outcomes of our health comes from healthcare. So we have to figure out, we don't just stop there. We have to figure out how we can take care of the rest of that.
I've not had the opportunity to be as impactful as Dr. Slezlon has in his career doing this work, but when I started this over 10 years ago, it was one thing to say someone's has a food insecurity. And we provide them now the food. Lindsay, I'm going to pivot to you first on this next question and asks, who do you utilize? When you utilize the food pantry, there's a potential of looking at connecting them with a dietitian when they need to utilize this service, again, to help them make meals out of the food pantry food, cooking with different seasons and etc. What I have found is that, yes, you can provide them the food, but for so many of these folks who struggle not only with food insecurity, but it's truly the lack of education in food preparation. And so it's much easier, again, to buy some of these things that are prepackaged, full of things we don't want them to consume, versus now I've got a bag of goodness. And how do I make sure I'm preparing this appropriately? Can you walk through a little bit of how Vera is looking at that, and others? I'd be interested in how you're addressing that.
Yeah, I think this is one area that we still probably have a lot of opportunity in, if I'm being honest. We do, so Vera St. Benedict is a critical access facility in a town of about 1,500 people. We do have a full-time dietitian who we employ here, and so we have access to, getting patients arranged with a dietitian appointment if they're willing and able to meet with them. I think the thing that really comes to mind first, though, is building that level of trust. So having the providers, number one, understand that they have food insecurity, and then relaying that to the dietitians that are being sensitive to that topic. It's helpful for the dietitian to know when they're providing recommendations and in helping counsel that patient that food insecurity is going to be a decision maker for them and what they're purchasing. So really starting with that level of trust and education, kind of facility-wide. We can't just make a dietitian referral for those that are food insecure and not recognize that. At a system level, we also actually recently started a weight loss program within our clinic that is in collaboration with Avera Health. So it's the same weight loss program that's evidence-based all the way across the Avera system. And there's access to dietitians virtually through that program as well, which has really been a helpful tool as well for patients who are not always able to get to the clinic to meet with our dietitian. They can do a virtual dietitian visit through that program. And that's been a great resource for our patients as well.
Anna, Dr. Slezlon, if you do anything differently to address that piece of the dietitian and the appropriateness of preparing?
Sorry.
Go ahead.
I would say, I guess I would say for our clinic, we have such a different cohort that embedded in the clinic are quite a few dietitians that are already talking to families because, for example, we have a large pediatric gastroenterology practice. So many of these individuals have special needs. I would also say that, so we try to educate with dietitians, but I would also say specifically with what we are giving the families. We have been incredibly pleased that we feel like we're giving them high nutrition foods, that we're giving them produce and and proteins that can last a couple of different meals. And so we are setting an example by what we are giving, that these are high quality foods, and I would hope that in some ways we're helping them with that.
We do have dietitians on staff, and so there is that opportunity for referrals to dietitians. Another piece that we are focusing on, which is not directly to specific patients. I'm sorry, everyone, I don't know why I went pink and purple. Anyway, but part of it is that community education piece. And so we actually have a mobile teaching kitchen that we like to take to large events, fairs, gatherings out across the Black Hills. And what we do there is, it's once again that trust level, creating space to bring community members in, and it's a hands-on learning how to make a recipe. And I'll talk a little bit later about it in my presentation, but we try to then tailor those recipes and cooking demonstrations to the population or the event that we're at, because we really want to make it easy then and enjoyable for our community members to take the recipe home with those tools and then go be able to make it for their families.
Now, Jennifer, I'm going to make a big swing here. I know that they've got presentations. Do we want to just pivot and allow them some time to do that? Because I've been asking lots of questions. I've got even more questions for them, but I don't want to get off script here.
Well, I think, it's up to them. They covered a lot of what was in their presentations, but I have them ready to go. If there's high points that any of the panelists would like to note in their presentations, I'm happy to do that.
Let's do it. I mean, again, if there's certain things they want to try out, let's take the time. I know they spent the time putting together, so I want to be respectful of that. So, Lindsay, I'm going to start with you. Jennifer, if you can find her slide deck, and then Lindsay, just pop through where you think you want to dedicate, a few minutes here. We've got about 20 minutes left here this afternoon, so I'll let you start where you're.
Jennifer, I'm just going to have you probably pop forward to, let's see here, slide 7, where it says Wellness Pantry. I'll just kind of talk through maybe a little bit of our process and what we're handing out. There we go. That's perfect. So again, I think I've covered a lot of this really through our question session here, but just to kind of touch a little bit on what our Wellness Pantry looks like and how we operationalized it. So again, the Wellness Pantry is just really housing, a food source that we can administer to patients when they present to our clinic and say yes, that they are food insecure. You can go to the next slide. For those of you that are, let's see here, there we go. This is just the screening, or excuse me, the resource form that we are also giving to every one of our patients who screen positive to food insecure. It's on the right side there. So this comes in the bag that we are handing out to the patients when they leave our facility. So the mentality really when we developed our Wellness Pantry was we have great access to food sources in the community of Parkston and really Avera Wide and Sioux Falls as well. But the Wellness Pantries were started with the notion that this is an emergency supply to food, and then we have additional resources that we can hook them up with to make sure that they're successful longer term. So making sure that every patient gets the handout for the additional food sources is an important piece of giving that food supply to patients. I already talked a little bit about our food or our produce prescription program that we have in Parkston, and that's also been very successful. Again, that produce prescription goes in $15 goes in each bag, and that's handed out to the patients when they screen positive for food insecurity. Next slide. This is the social determinants of health screening that we're doing. Again, as we talked about, it's pretty quick, very painless for the staff to ask the 2 questions within the past 12 months. Have you been worried about your food supply, or have you run out of money prior to being able to buy groceries? If they answer yes, they fill out the EMR documentation. So there's not additional work for our clinical staff, making it very efficient and meaningful for both the clinical staff and the patients. Next slide. This is just a picture, I guess, of one of our nurses taking food off of our food pantry shelf. And we already talked about funding through Feeding South Dakota and Healthy Start programs and other grant partnerships. So I don't know that I need to touch any further on that. You can keep going. So I'll just really talk through our process. I think I've covered a lot of this, but again, patients present to the clinic, hospital, or emergency room. They're screened through our social determinants of health. They're given a prepackaged bag if they screen positive. All of the tracking and documentation is done through the EMR, so there's not additional paperwork. Our staff is trained with food safety training. I'm sure others could comment on that as well, but just to make sure that we are handling the food product appropriately and monitoring turnover. Again, I talked about the produce prescription, so I don't really have much more to add. And then, of course, making sure that they are receiving other local resources to ensure their success long-term. This is just an example of our reporting information. So Avera currently has 5 wellness pantries that are open. There's 4 open in Sioux Falls and 1 open here in Parkston, which is the only critical access facility so far that's had a food pantry that's been opened. Total bags provided for Avera, Sioux Falls is 758. And for Parkston, we started our wellness pantry back last November, and we've distributed over 100 bags so far, which is about a 10% food insecurity rate locally. And it's much more than I think we ever anticipated here. So you can go to my next slide. And this is just a little bit of a picture of our process. So the food arrives on pallets that you can see on the left. We have a local volunteer group who comes in and helps bag the food. We have kind of a set, protein, grains, fruits, vegetables, complete meals that we put in each bag. They get the resources, the produce prescription, and then it's set on the shelves so it's ready for nursing staff to take when patients are screened positive. And the bottom right is just a picture of our nurses taking food down the hall to patients if they had screened positive. So that's it.
Thank you, Lindsay.
Yes.
Dr. Seslon, I think we're pivoting to you. See what you have.
Sure. And I think I went through a lot of this material already, but you can start on the second slide. And I would just say it was already pointed out how important nutrition is for health. I would say anecdotally, as an intensive care physician, it's always interesting to me that one of airway tubes and arterial and venous catheters, at the same time you do those, you put in a feeding tube. And there's a reason for that. And even critically ill patients, how important nutrition is to healing. Certainly we see this in chronic conditions, but also recovery from illness, surgery, chemotherapy. And with children, I think it's obvious, but the developmental delays. And I would say also with children, the psychosocial stressors that the entire family has to deal with when there's food insecurity. It is a real issue. And so next slide, please. And I think I kind of went through this already. I would just say that Sanford's landed on a 2-pronged approach. Our first approach is to significantly financial contribute to our food resources in South Dakota. That would be Feeding South Dakota. Really trust their leadership and their connection to their purpose. We are aligned with their purpose and want to partner with them and continue to sustain that. On the second part of that would be in our rural areas, especially, how do we operationalize both? Some places are setting up food pantries and wellness pantries. Those that can do that, that's great. But even if you do that, we still need to operationalize how in those communities we can connect them to the resources they need. So you can go to the next slide. And that's just the rural. You can go to the next slide. And I think I appreciate those slides that were just shown. I've already talked about the Kids Kitchen. We started in 2023. We had an inclination that this was going to be, that our families were experiencing food insecurity. It wasn't until we started screening that our rate of food insecurity is nearly double the national rate. Now, our Kids Kitchen, our Sanford subspecialty clinic, it's a different cohort of patients. They are all subspecialty patients. Many of them come from great distances, and many of them have chronic health needs. And so what I would say is food insecurity in many of these individuals They are also hurt by cuts in Medicaid. And so that also plays into some of the stressors that they are dealing with. Currently, as I said, we distribute about 5,000 to 6,000 pounds per week. We count individuals in the household. So in 2024, it was about 22,000 individuals because we give enough food for the entire household. And then we started in 2025, the second Kids Kitchen on the campus, which affects maternal health. Maternal health, as we all know, is something that's not doing very well in the United States, particularly in women of color. We believe that diet has a lot to do with that. And so we are distributing it to maternal health, peds. It's an urban practice. It's primary care, and then women's health as well. And then you can go to the next slide. And I think this was mentioned earlier, every health system every 3 years does a community health needs assessment, and food insecurity continues to be high in the priority. We use those assessments to drive our strategy to help our communities. And so we will anticipate to continue to do that into the future. Thank you.
Thank you, sir. Anna, anything you'd like to show?
Yes, I will be real quick. Can you go to the slide with, I think it's the next, or two, the next two. We'll skip over what Monument Health is there. So I guess I talked a little bit about our wellness pantry. I did want to give a couple examples of how we use our mobile teaching kitchen in a way that's catered to the audience. So example, Black Hills Stock Show, we use beef forward recipes that really allow us to highlight our agricultural background, while also then having that nutritional piece to it and making it easy for people to go back and have those balanced meals. Youth and Family Services Kids Fair, we like to find simple, safe, and engaging recipes that children can make themselves in case maybe there isn't an adult around, or if there is a family around, it allows them to build those healthy habits together, which is so crucial. Another piece is our cancer survivorship event. We really try to focus on those nutrient-rich meals because for our survivors and their families, they're looking for those practical tools to be able to help their bodies during and after treatment. So that's just a little bit of how we are going out in the communities, meeting people where they're at, and really trying to build those deep connections when it comes to nutrition and just wellness in general. You can go forward. I talked about the community health screenings. This is everything from free blood pressure to mental health risk assessments, hearing checks, skin checks. We at this time don't screen for food insecurities at these events, but that doesn't mean that that's not something that we can add into the future. But it does open those doors for deeper conversations about the health challenges that people are facing, and allows us to build that trust when we're giving people advice on how to take care of their health. Over the past 3 years, we did 52,000 screenings in hundreds of locations across the Black Hills. And then the next slide, the last piece that I want to point out with this is that community listening is really important, but one of our most impactful experiences that Monument Health offers is our Dakota Lands tour and health disparity seminar that we hold every year. So it's a multi-day journey, and we bring leaders internally and externally, community stakeholders, and we take them to nearby reservations to learn about historical trauma, some of that systematic inequalities, and those lived realities of our indigenous relatives. And so what this tour does is it's not educational, it's really immersive, and it challenges all of us, honestly. The people that go on this, we sit back and say, okay, what are we misunderstanding? Maybe what are some of those biases? How can we treat our patients better and connect better with our community members, now seeing and truly understanding some of the challenges that they're facing? And so, long story short, we can't do this without our community partners, and we want to continue to be collaborative. And just like everybody on this committee, or on this panel and this committee, there's a lot of work to be done, and we can do a lot better if we're working on it together.
Well stated, Anna. Again, honored to have this group of folks with us today, doing tremendous work, valuable work. I think a lot of folks look to these three extremely important health systems as filling a gap within our communities. I can't say enough. It's been mentioned a couple times about Feeding South Dakota and the profound impact they're having, not only with the work they do, but also on the work that these health systems are doing. So I can't say enough to Stacy. It's been truly a pleasure to work with her over this last year. I'm going to try to do a Stacy speed round. So we've talked about Feeding South Dakota and their impact. We've talked about the government issues that are coming forward within the recent reconciliation packages. Do you feel that, again, those federal funding pieces that have been so important to a lot of initiatives, do you feel like those are going to impact your work very much as health systems, or do you have a way to kind of withstand some of this initial pressure? Lindsay smiling, you get to go first.
I felt it coming. Oh boy. I think that's kind of a loaded question, but yes and no. I think, we live in an environment where as healthcare leaders, you're kind of always ready for those things, in a sense. You kind of have to keep a few things in your back pocket, maybe per se. But of course, there's going to be challenges. And I think the important part is just really sticking true to the reason why we're here and what we're doing, and then kind of pivoting as we need to. But certainly looking at different models of sustainability, different options for funding, other resources that we can send patients to, like Anna had mentioned, really leveraging community support, I think is important. And just keeping that at the forefront and being willing to pivot and not just, throw in the towel when it gets tough, I guess, is maybe just my very off the cuff answer.
Thank you. Dr. Schlegelon, Anna?
Well, I think we probably share the concern of many people on this call with cuts to things like SNAP and potentially to Medicaid. The strong Medicaid program is very important to many of the individuals that we were talking about today. And so we'll continue to advocate, and we'll continue to, as Lindsay said, pivot when we need to pivot. And we'll continue to try to be on the side of the right side.
Well stated. Anna, you get the last word.
I would just echo everything that everybody else has said. That flexibility is something that is really important to us. We know that we don't have a crystal ball and can see into the future of what these impacts are going to really look like. And we also know that one little change over here can make a huge impact over here. And so we are trying to do our best to be proactive and look ahead, while also just sort of writing out some of these along with our community. But it comes back to it of, as the community healthcare systems, there's a responsibility, and also our community looks to us to be those leaders in making change. And so we take it really seriously in making sure that we have a seat at the table in all of these different discussions, so that we can make sure that we add our piece in the collaboration of coming together for whatever happens.
Agreed. Anna, Lindsay, Dr. Schlegelon, thank you very much. Appreciate the wonderful comments and what you've been able to share with us today. I know that as we approach the end today, I want to turn it back to Jennifer and kind of share where things are headed and invite any ideas you may have. So Jennifer, I'll turn to you. Thank you.
Thank you for that excellent panel. And I would say we had a lot of great engagement in that one. So thank you all. Again, I'll just echo Dr. Renshaw. Thank you all for being willing to speak and share your expertise. So as we finish up here, I do just want us to get, I'm sure the juices have started flowing and you're thinking about ideas. I've already started having people are emailing me with ideas and thinking about what we can do for the future. And so I just wanted to just say, what we're thinking right now, and then invite you to contribute to that now and then over the next couple of months as well. So in year 2 with our goal groups, we are going to continue to do that work. So we created action plans. We have people that are going to the meetings, creating the plans, and then working with their networks to build out the activities under those plans and to do the work. So that is where our priorities and will take shape, and that is where the action will happen. We are going to be thinking about new strategies. We will probably pull some strategies from our first year over into our second year. As we're thinking about the collaborative's leadership in year 2, that landscape assessment in the next year, we're hoping to be complete or very close to complete. And so that does take coordination with the goal groups and with our leadership and our research partner at Avera Research Institute. Looking for our annual report in year 1. So we officially launched in September of last year. So I'm hoping that by September or October of this year, we will have a year 1 report that will be shared. And then we do want to increase our reach and awareness of the goal groups. And I think this meeting hopefully did that, got us going on our way. And, for those that like models, I'm not going to spend too much time on this, but I do want to share that we do have logic models. So thinking through what are our short, if you go to the right side of this graphic, if you go to the right side, so we're looking at the outcomes and impact. We do have short, medium, and long-term goals associated with the work of each of these goal groups. And so, thinking about how we build that out, and you'll see we only have one long-term goal right now. So we're going to have to really think about how and what what the work of this collaborative looks like long-term. So, Dr. Bastian, I was wondering if you could put this link in the chat for me. But after listening to the presentations, would you be able to provide your thoughts on any opportunities that you see in the coming year for the South Dakota Healthy Nutrition Collaborative? And it's going to give you a link to a Menti. And so you'll be able to put in a couple of words that you think might be opportunities for this collaborative. And as those come in, I'm going to go ahead and share this screen. Yeah, so keep typing in your words. Let us know what you think. I'm just interested, what stood out to you as far as opportunities? What did you hear from other organizations or other leaders, either from out of state, from our food policy group, from our in-state healthcare systems panel? What stood out to you? So I'm going to give you maybe a couple more seconds to add in a few words. And I got to tell you, my little heart is beating really, really like fast because collaboration is right in the middle of it. And that makes me happy. It makes me feel like, okay, we're doing a good job. If people feel like that's still an opportunity, that there is still value in the collaborative and what we're doing and what we bring to this. So that will stay open to you. Some other things, I think it's interesting that folks are noting advocacy, support, connections, education, policy development, tribal engagement, Tiashpe, love that, family, farm to school, positivity. These are great. I'm so glad that, we're ending this year with this as, looking to the head to our second year. And this is where we're going. That makes me feel good. It makes me feel like we have a strong team that's ready to act and to work. So I just also want to share, before I hand it off to Tim, who's going to leave us with some inspiring notes, I do also want to share that we are interested. If you're interested in ways to engage, if you already are not engaged, you can join a goal group. You can join our listserv, and you can share your story. So Dr. Bastian, if you wouldn't mind putting that link in there, it's just a form, and I will follow up directly with you if there's a way that you'd like to engage, and we can get you plugged into some of these efforts. So please feel free to fill that out, and I will absolutely follow up with you. So with that, I think I am going to turn it back to Tim and say, I'm going to say thank you. What a wonderful conference. This is a really inspiring group, and I look forward to year 2. But I know that Tim Meager, who is on our steering committee, also is going to leave us with some inspiring words and thoughts for our second year. So Tim, why don't you close us out?
I feel pressure here. And to be completely transparent, I am really organized, and I did not bring my computer charger. So if it cuts off right before my mic drop, I apologize. But so I've been marinating on during the last couple of hours on I pay close attention to what are like themes of success in terms of like outcomes, and we got to hear some amazing stories, and it was all centered around collaboration, which I kind of chuckled because that's literally in the name of what we do. And I was thinking about like this all connects, like river systems and the capillaries of river systems, and how important in streams are to river systems, and how everything affects everything, and what and at the end of the day, what can we use as a pillar to fall back on? And every single person on all of the panels that show up to these conversations in some form is serving our own humanity, as well as the humanity of everyone. And that's a simplified way of saying it, but it precedes a lot of belief systems, and to me, it speaks to the truth of why is it that we exist together. And so sitting here listening to the brilliant people talk today, I think all of us in some form have hit some like headwind in difficulties and obstacles, and through the collaboration together, I use this term a lot, like flow like water, flow around the obstacles, and come together. And how much time do you spend on the obstacles versus seeing what opportunities can come when we share together? And that's kind of the energetic piece that I took from all of this today, was at the end of the day, we can fall back on each other, and when we put our heads together, those new opportunities will show, and we can trust that in our efforts together.
Thanks, Tim, and thanks everybody for joining us today. I just will add on and say that I'm glad that we're tackling these headwinds together, and we will have more challenges ahead, but glad that we're doing it together. So thanks, everyone.
Thank you, Jennifer.